Right, good morning, and I would like to welcome everyone to today's Health Scrutiny Committee, including everyone present here in the Council Chamber and those who are listening online. Before we begin, for those of us in the Council Chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the Council Chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instructions. I would also like to welcome Councillor Colin Matthews, who is attending as the Executive Support Councillor for NHS Liaison, Community Engagement, Registration and the Coroner's Services. Other participants will be introduced when we reach their item. I would also like to welcome all of those listening to the live stream of this meeting through the website. And I'd also like to welcome our new member to the committee, Councillor Tom Smith, so welcome. I'd also like to, at this point, ask for all mobile phones to please be switched off or placed on silent, please. Now I'd like to move into agenda item 1, apologies for absence and replacement members, please.
Thank you, Chairman. We've received apologies for absence from Councillor Sandra Harrison, Councillor Glynis Scalesi and Councillor Rosemary Cavery-Brown. And as you said earlier, we've got a replacement on this committee. Councillor Tom Smith has replaced Councillor Reid. Thank you.
Thank you, Trina. I'd like to move to agenda item 2 now, declarations of members' interests. Do members have any interests to declare at this point, please? No? Okay, in which case I'd like to move to agenda item 3, the minutes from the 10th of November 2021. I'd like to confirm the minutes of the meeting as a correct record found at pages 3 to 14 of the agenda pack. There are 2 typos, firstly on page 13, minute 48, resolution 1, which should read be noted, and on page 14, minute 49, it should read patient transport. With these amendments, and as the committee have had the opportunity to read these in advance of the meeting, I plan on taking these en bloc. Do I have a proposer, please? Thank you, Councillor Ray Wootton, and seconded by Councillor Linda Wootton. All those in favour, please show. Thank you. Abstentions? Thank you. And those against? Thank you, that's carried. In which case I'll now move on to agenda item 4, the Chairman's announcements. My announcements have been circulated with the agenda, which is pages 15 to 39, and my supplementary announcements were emailed on the 14th of December. Are there any questions on these at this point, please? Okay, thank you. In which case I would like to propose that the Chairman's announcements and supplementary announcements are noted. And secondly, that the Chairman be authorised in consultation with the Vice Chairman to respond on behalf of the committee to the consultation on intermediate minor oral surgery, advising NHS England that intermediate minor oral surgery should at the very least continue in the existing 5 locations in Lincolnshire of Lincoln, Boston, Grantham, Gainsborough and Skegness, and consideration be given by NHS England to extending the provision to other towns in the county. Do I have a seconder for my proposal? Thank you, Councillor Smith. All those in favour, please show. Thank you, that's supported. We'll now move on to agenda item 5. But just before that, I'd like to ask that you all keep your questions and contributions succinct and concise, ideally no more than 2 questions per item. And I would also like to stress the importance of treating all our contributors today with respect and to bear in mind our role as constructive scrutineers. I'll now move to agenda item 5, which is the Lincolnshire Acute Services Review, Orthopaedic Surgery, found at pages 41 to 71 of the agenda pack. And I'd like to welcome our presenters who are joining us via Teams, Mr. Vel Sakival, Consultant in Trauma and Orthopaedic Surgeon for United Lincolnshire's Hospital Trust, and Pete Burnett, Systems Strategy and Planning Director for Lincolnshire NHS. If I can hand over to you for about a 15 minutes presentation, and we'll take questions at the end. Thank you. They're both there, aren't they?
They are there. They're in the appointment.
Oh, I can see you now, Pete. He's on mute, isn't he? You are on mute, though, at the moment.
Right, that's better.
Brilliant.
So Val, do you want to talk through the proposals?
Thanks, Pete. Thank you. Can you hear me, guys? Yeah.
Yeah, we can hear you. Thank you.
Thank you. Thank you. Thanks, Chairman and councillors, and Pete and Simon for helping me with this. So essentially, summarize the presentation and the summary points in the paper. We all know that we have an acute services review in place. Essentially, the whole of the orthopedic services at the county is being reconfigured as part of the services review. We class them, to simplify matters, we class them as planned care or unplanned care, which is basically the difference between someone having a total hip replacement planned versus a fracture, femur or thigh bone from an accident, which is an unplanned care. So previous to this, we had services in all three of our main hospitals in the county, and Louth had just planned care. So all Grantham, Pilgrim and Lincoln hospitals basically had both planned and unplanned care, and Louth had planned care only. And then to further divide planned care, we have day surgery, which essentially means the patients are in and out on the same day after having treatment. And then we have in-hospital stay, which is basically who stay in overnight and more. So these are the broad classifications of the groups of patients we deal with. So now the proposal is to reconfigure our services. So we have planned in-hospital care based at Grantham, which is our proposed center of excellence. We also can do day surgery planned care at Grantham. Lincoln and Pilgrim remain our hot sites or sites for our unplanned care because of the presence of support systems like the intensive care unit, the cardiology team, and etc. and so forth. So we have our complex patients who are dealt with better, and in trauma patients dealt with better at Lincoln and in Pilgrim. Louth Hospital remains our center for day surgery planned care. Whilst I say that Pilgrim and Lincoln will continue to provide emergency work or unplanned care, we also have provisions to provide planned care for a small select group of patients who require it. This is based on their significant medical comorbidities and other medical challenges we may face. Again, for the reasons I mentioned earlier, because Lincoln and Pilgrim are better placed with their support systems and backup systems to look after any post-operative special need should the patient need it after the operation. So this is our proposal. And for those who do not know, we already have been practicing this as part of a national pilot, which was directed to us by the National Department of Health, GIRFT board, which is the Get It Right First Time. And we have been practicing this as a pilot since August 2018. And this did show significant amount of improvement, which has been highlighted in our report presented to you. Unfortunately, COVID struck and our improvement clearly wasn't sustained for obvious reasons. But essentially, we did improve on a vast amount of metrics about patient cancellation, for example, went down from trust-wide about 1,200 patients on the day to virtually zero at Grantham. We then had a significant amount of staff issues, recruitment and retention issues pre-reconfiguration. We've had that successfully improved since. We've also cut our agency costs, which we needed for medical agency to cover 3 different rotas, and now we're doing it with 2 rotas. And we are providing this extra bit of clinical work with less number of theatres which we had to use. Another metric is the length of stay for these patients in hospital. We are now considered one of the country's best in terms of 1.3 and 1.7 days for hips and knees, and we are being spoken about widely by the GERF board as a success of one of the pilots. So the various metrics, as I mentioned to you, and many more in terms of the referral to treatment percentages and things improving are all present in the paper we presented. So that is in a nutshell of our proposal, what we did prior to the reconfiguration and what we propose to change. And we are in a good position because we have been in a pilot since August 2018. So nearly all the metrics we give you in front of you is basically not speculation, is actually what we've actually witnessed in reality. And that's all I wanted to mention. I don't know if Pete wants to come and add a few more things, but otherwise I'm happy to take any questions. Thank you, Chair.
Just to add, this was part of a national pilot that was led by Professor Tim Briggs, who is the National Director of Clinical Improvement for the NHS, and previously was president of the British Orthopaedic Association. So you've got someone who's fully behind it and actually champions the change here as best practice nationally, certainly for multi-site trusts. Being a key kind of aspect in the kind of delivery that we have locally in that regard. So it was his he came up and led the pilot, and he sees it as a complete success, which is good news. Also, I think the fact that more patients now choose to have their surgery at ULHT, at Grantham Hospital, than previous to the pilot, that we had a lot of people going out of county, either to other providers or to the private providers paid for by the NHS, is also shows the success of this work, and which is good to see. Happy to take some questions though.
Okay, thank you very much for the presentation. My first question comes from Councillor Ray Wotton.
Thank you very much indeed, Mr. Chairman. The question refers to page 59. You talk on that page about affordability and deliverability. It's a long word. You say that there's 16 beds, 8 elective and 8 non-elective, and you're also going to try and get up to 20. Can you tell me where are the staff going to come from to service those beds? Because we've received complaints, not only this week, that there is a lack of staff to give care at Grantham Hospital in the orthopaedic unit. Thank you.
Can I take that, Pete?
Yeah.
Thank you. So staff recruitment has been a significant challenge pre-reconfiguration. It has improved since the reconfiguration since August 2018. However, the present question is very valid because we are now posed with significant challenges posed by the epidemic, and hence there have been staff reallocations to other places. So what we have to do at the moment is when we propose to increase the beds, it's because of our success based on the amount of or the reduction in cancellations and the people being wanting to have treatment within Lincolnshire. So hence we propose the increased number of beds. However, presently, I totally agree with the councillor that the challenges do remain in terms of staffing these beds. That is mainly because of the present COVID epidemic rather than any other issues. So I'm hoping that when this epidemic plateaus out and our recruitment goes back to how it was previously, we would improve on that. Thank you.
Thank you, Chairman. Could I ask then, do you believe at the moment, or the present time, that you've got enough staff to cope with the current patients that you have? Thank you.
Yes, we do. We have for the present number of beds, and the present number of utilization of both wards and theatres, yes, we do have the number of staff. And I tell that because prior to the COVID epidemic striking us, we were about half our surgeons were doing 5 major joints a day, and the others were doing about 4 major joints a day, and nationally 4 major joints is the benchmark. So now, however, because of various other challenges posed to us by the epidemic in terms of isolation and in terms of the infection prevention issues, we are not doing as many patients. And hence, even if there are fewer staff members, we do feel that we can cope with the present workload at the moment. Thank you.
Thank you, Councillor Wootton. Councillor Smith.
Thank you, Chairman. At 9.14 in the report, it states that ULHT have issues delivering the optimum mixed capacity of elective and non-elective beds. And it goes into that report in terms of travel, and that's an issue for patients as well as staff. And surely this highlights that the issue of distance and travelling distance is actually more than a minor inconvenience, as the report sort of intimates. Surely the review, as I've sort of said, it's contrary in its tone. At appendix, the statements made in Appendix A of the report, what detail can be provided in a fuller manner of the impact and the possible distance required to travel for surgery? Because at the moment, the impact assessment on that, having read through it, to me is quite vague. Thank you, Chairman.
Sorry, I understand that the question is about travel and the impact assessment. So in terms of traveling, yes, when we proposed the reconfiguration and when we discussed that in our pilot or during our pre-pilot discussions, travel was brought into the discussions because of our vast county. Now, during the pilot, we actually have not received, and this is not talking about the impact analysis itself, but I'm talking about reality. We have not received any complaints in terms of the datixis or IR1s about the travel itself. People are willing to travel. In fact, Grantham ward and hospital care has been commended by many patients, even though they were traveling from close to the coast, in terms of the care and the treatment they receive. So what I would suggest is, although I'm not able to answer the exact specifics on the impact analysis per se, but I'm just wish to tell you the actual reality on the shop floor, that there is not, the people are willing to travel to especially to the Centre of Excellence in Grantham, because there's a much higher chance, in fact, practically 100% chance of actually having their operation confirmed rather than traveling to a much closer hospital with a significant risk of cancellations on the day. Sorry, Pete.
Yeah, it's just to say exactly that. So 9.14 is the case for change, since the historic position, and I think cancellation rates on the day were around 30%. So just travelling locally, actually having your sitting there all day and then having your bed taken up by an emergency patient wasn't ideal, and the evidence does show that people are willing to travel. Also, if you can't, the nature of this kind of surgery means that you wouldn't be able to operate a car, and therefore would qualify for patient transport at the same time. That probably plays into that kind of area where Val has said that actually people have shown no complaint in terms of travelling across, but having it here means that people sing quicker, so live in pain for less time. They're almost guaranteed to have the surgery on the day that they plan it in for, and as part of the preoperative assessment, that travel requirement is looked at, both the distance and time, and therefore the surgery scheduled at a time that's suitable for the patient to get in, and I think that's the key in that sense. What this does, it leaves people have living in less pain, or having their operation as quickly as possible, in a way that is almost guaranteed, as Val said, because they're not cancelled on the day, because it is ring fenced in an elective centre.
Thank you, Chairman. As someone who's had orthopaedic surgery out of county, in my case, I'm well aware of the difficulties in travelling. Certainly after surgery, it was quite comical, shall we say, in my situation to travel back from Nottingham. It's good to know that they would qualify for patient transport, because that's not made overtly clear in the impact assessments. That sort of assuages the concern I had around those that, say, didn't have a car. And obviously, if you're having surgery on your legs, you can't then go and use public transport particularly easily. In terms of, and it's a very brief question, the on-call function at Grantham is no longer being or is planned to no longer be a consultant. Could we have advice how you will, shall I say, dissuade or assuage fears around the risk of, because what the public might see as de-skilling that function, and how that's being catered for in comms?
The on-call function is not present in Grantham for the elective patients. However, there are consultants who are on call, because all the consultants who were originally based in Grantham have been absorbed into on-call rotas in Lincoln and in Pilgrim. And hence the de-skilling part of the consultant doing on-call work or trauma work is not in any question, because they are still part of the trauma work in Lincoln and Pilgrim. In fact, I would say that it is slightly better, because of the number of cases coming through Lincoln and Pilgrim are higher than number of cases coming through previously at Grantham. In terms of the patients having any concerns about the lack of consultant on call at Grantham, we can assure them that, as I said before, there is a consultant on call, and there are people who are on call on the shop floor, medical colleagues who are on call on the shop floor at Grantham for these patients, who have instant access to the on-call team at Lincoln and in Pilgrim, and there's a specific rota which goes out, which everyone knows, and so it's not like a call person A, then if not call person B, if not call person C kind of a thing. There is a named person who they can call and get advice over the phone. We initially set out that if any patient does require overnight treatment surgically, then that patient will have to be transferred across to Lincoln and Pilgrim for overnight surgery and any invasive treatment at Lincoln and Pilgrim. I can assure the meeting today that no single patient from 2018 August has had to be transferred. There was one who might have been transferred because of issues, but after discussions with the consultant, that transfer was not required. So no patient had to be transferred overnight. No orthopedic patient had to be transferred overnight to Lincoln or Pilgrim. But also, this is the same model which is being practiced in other providers, where there is like an RMO, resident medical officer, on the shop floor looking after patients, but then call their consultants if needed for any more specific specialized treatment. Thank you.
Okay, thank you. I've now got Councillor Allen.
Thank you, Chairman. My original question was actually asked by Councillor Wootton, because I'm very keen, as I'm sure we all are, to see that these proposed changes do bring real benefit to the people of Lincolnshire and the people that need planned orthopaedic procedures. The question I got is, how many, it's to do with the challenge that was raised right at the beginning of the paper, which is 3,000 patients were put into the private sector to have their procedures done, paid for by the National Health Service. I'm not totally sure as a patient I would see that as much of a challenge, to be honest. It might be quite preferable from my point of view. But how many, if there's 3,000 that are outsourced, what proportion is that of the overall number of planned procedures that are actually taking place? And if that is seen as a challenge by our colleagues in the National Health Service, is the changes that are being put forward being seen as a way of bringing those 3,000 procedures back in-house? And if that is the case, it seems to me then that there is no real benefit to the people of Lincolnshire, because it's the same number, it's just taking place all in-house rather than being partly outsourced.
It's a question on numbers. Prior to the reconfiguration, our market share was around about 45%. So what we aim to achieve is to repat patients back into the county. So initially, I completely agree with the councillor asking the question that it's the same group of patients rather than having to go outside, come into Lincolnshire for treatment. However, what we aim to also achieve is once we have tackled our own health challenges, so those particular 3,000 patients has been mentioned, we then can show the world and country and wider areas that we are who we are and how we work, and we can get more patients from outside the county to come in. So our work will improve. Now, you might feel that this is an arbitrary answer. However, we were aiming to get prime provider status from the CCGs because of how we worked, and we've had our initial meetings. Unfortunately, that has paused because of COVID. And once COVID settled, we are going to restart those negotiations, which does mean that we get prime provider status, which again, it helps with getting patients back in. Also, now we know, I've been in meetings 2 weeks ago from the regional board, deanery related board, to actually ask us how we do this, because Nottingham City, for example, are not doing any elective surgery because of COVID. Now, it might not be directly related to the actual reconfiguration, and COVID might help, but there are questions about whether we can take their patients to help within at Grantham. So the talks are happening, and although I can't sit here and actually give you numbers because COVID has had a lot to answer for, but I think once we prove to everyone what we are able to achieve, there is a good negotiation, good talks to be had to get patients back in. So I'm hoping that 3,000 would improve, but I can't sit here honestly and give you an honest number to show that it has improved. Thank you.
Just 1 minute, I've got Pete that would like to come in first.
Yeah, and just on that, so I think the previous question was around transport. There isn't a great deal of private provision in Lincolnshire, so most people were travelling further than they would need to travel to Grantham, travel hospitals, private hospitals in Peterborough and in Nottingham in that sense. So actually, having them in means they travel less, but also the benefits is even if it's the same number of those 45% of patients that choose to have their surgery at United Links, about 30% of them were having cancellations on the day, and therefore this procedure, even if it just stayed at 45%, actually that's been eradicated, which is a significant improvement to those patients who do choose to have their surgery there. It is a benefit to the NHS because we have a facility there, and we want to use it as much as we can, and it helps grow the team and make the workforce stable. So it is helpful to bring that activity back in. But even if it stays as it is, the benefit of this pilot has been demonstrated in the reduced length of stay and kind of reductions in cancellations, which is significant to the patients who need the surgery.
Councillor Allen, you'd like to come back?
Yes, I wanted to come back on. I'm not totally sure I heard it right, but I think he said. I think the consultant said that the 3,000 represents 45% of planned procedures. Is that right?
Sorry, Councillor, no, that's not what I meant. What I meant was prior to the configuration, our market share generally was 45%, around about 45%.
Right. So does that mean that 45% have been externalised?
55% were going out. 45% were being treated at ULHT.
Oh, so it's 55% really going outside. So I'm getting to the stage where I'm starting to think about whether I need hip or knee replacements, and whether I'm actually likely to get them at all before I peg out. And it does seem to me the answer that we actually got was that we've got major problems with COVID at the moment, which we understand. Although we do understand, the significant consequences, and when COVID is going to, COVID concerns are going to get to the stage where we can actually go back to a proper National Health Service, is difficult to understand at the moment. So we've got COVID causing problems. We've got a significant backlog of procedures as a result of COVID. And from what I heard in the response, the first call for any new beds that become available will be to start bringing these procedures that have been done externally back in. It does seem to me that we're not going to get any significant improvement in terms of the number of planned procedures that are actually taking place in Lincolnshire for some considerable time, and probably beyond the years that I've got left on this earth. Sorry, Chairman, I'm not very happy with that.
Yeah, so I'm not sure that's necessarily the case. I think we're comparing what was a business case that has data on a pilot that was pre-COVID, and COVID has disrupted elective surgery capacity. I think the beauty of this, the fact it's ring fenced on Grantham, means actually a lot of elective activity continued during the COVID waves, where it hasn't, as Vel said, in Nottingham City, because that is also has emergency patients that come onto the site. That's impacted on their ability to do their orthopaedic surgery. The way going forward is that the private sector is being fully utilised to draw down those waiting lists, and therefore it's not at this stage. The business case was predicated on bringing activity in from private providers, but at the moment the NHS focus nationally, utilising the private sector and our own kind of capacity, is to reduce the waiting list size down as much as we can. And I think if you look at the long waits, which is still unacceptable, but actually ULHT are very favourable in terms of their long waits, long waited patients compared to other systems quite considerably. There's still a lot of work to do, and I think the whole NHS is trying to work through that backlog as we go through. But under this proposal, the fact it's ring fenced, the fact that, as Vel said, you've got surgeons who are doing more procedures or doing more operations than the national average prior to COVID, and obviously IPC, infection prevention control measures, have slowed some of that down, does mean the throughput will maintain high in Lincolnshire by ULHT. Val, I'm not sure if you want to add to that.
Yeah, thanks, Pete. I can understand Councillor's question about the backlog and things. Yes, COVID unfortunately does have a lot to answer for, which everyone knows anyway. But going on from what you've said, Pete, the nationally the big benchmark at the moment is the 52-week breaches, because of how the elective orthopedics has always taken a backstage in relation to other medical and respiratory emergencies. Now, I can proudly sit here and say that Grantham/ULHT in orthopedics, we have no 52-week breaches which are undated. Now, I would challenge anybody to these figures when they speak to neighbouring health providers, NHS health providers, and because of the challenges they are facing. And we were able to do that only because of how we work in terms of the Grantham being a centre of excellence, and not only that, but also ring fence elective orthopedics with a significant reconfiguration we've gone through. And other workplace challenges which we have to work through. So yes, I do empathise with the councillors' angst about delays and about taking a long time to get back into what one would term normality in the NHS. But I can also reassure the councillor and everyone else listening that in terms of elective orthopedic care within the workforce challenges, we have improved significantly, and our backlog is not as bad as our other neighbouring counties and health providers. Thank you.
Chairman, can I just make a comment?
Very briefly,
because I think there was some clarification there in terms of some subsequent comments that were made. I mean, if the intention is to use the private sector to help address the backlog, I'm somewhat more happy than simply using the planned additional beds in the National Health Service to bring those cases in. So if it's a question of using the private sector help with the backlog, that's fine, and then you can start bringing them back in once that's happened.
Thank you, Councillor Allen. Yeah, I think it's throughout the private sector has been used to try and help, what with the COVID Green site in Grantham, as well as other services, to try and make sure that we're not as such a poor position as other counties, areas and so on. And I would actually commend our local NHS for doing that. So, okay, thank you. I've now got Dr. Wookey.
Thank you, Chairman. I think first I should say I'm here from Healthwatch Lincolnshire, and we've had feedback going back some time with these changes. And I think what is reassuring to some extent is you have had some experience over 18 months probably before COVID running the pilot, which is very similar. And I think the fact that that has gone well is reassuring, and broadly speaking, we have no problems with what is proposed. Just some detail then, if we could go back probably predictably about travel and the distances people have to travel and the effects on them. You've got examples which you've bravely put on page 67 of various patients' experiences, and one was a lady who lived in Skegness and had a total knee replacement in Grantham. That's 55 miles each way, which might be all right if you're driving in or being driven in a Rolls Royce, but I think that was as a day case, and the experience of the non-emergency ambulance service currently is that people brought home from hospital often end up very late at night getting home, even if they're only going a relatively short time or distance. But I think to have a knee replacement and arrive home at midnight at Skegness is really pretty stressful. So my first question really is, when would that lady or an equivalent person, perhaps 10 years older or 20 years older, when do they become somebody who has a longer length of stay than day case for an operation of that sort? How do you spread your risks and your day cases? The second question relates to people once they've come home, and they've got home, they had a relatively major operation. They're 55 miles from where they had it done. And although you've mentioned about there's a host of on-call people who will be involved as necessary, it's not very clear. It's a little bit of a grey area to me as to who is actually clinically responsible for that patient once they've come home. Is it the person who they saw at Pilgrim originally and who they'll probably see as a follow-up? Or is it the surgeon who actually did the surgery in Grantham? Some people may have a long memory and remember, particularly this comes back to the private sector, when a lot of people from Lincolnshire went over to Marlborough to have hips and knees replaced. And there was a big battle with Marlborough as to who was responsible once the patient came home. And they tried really to sort of opt out of any involvement, and that went on for some time before I think some sort of compromise was reached. So my second question is, are the follow-up arrangements satisfactory for anxious people who are a long way from the site of surgery? And, to whom do they refer to get some advice? Thanks.
Thank you. A good summary of questions. I would summarize my answers based on two headings, really. One is based on the day surgery practice, and two is the follow-up practice. I'm happy to answer any more after that if I have missed out on any particular point. So starting with the day surgery practice, to reassure the doctor, not every knee replacement undergoes day surgery kind of practice, although the whole concept about day surgery is improving, and we have done day surgery, partial knee replacements, total knee replacements, and total hip replacements. All of them were possible primarily because of the reconfiguration. However, when we choose a patient who will suit day surgery, we do take a lot of parameters into consideration. So essentially starting from their compliance with medications, their response and their behaviors to pain, their safety in terms of mobilization, and then, of course, their social circumstances, which would include where they live and how far they have to travel, etc. So there are lots of reasons and at times when we tick a few boxes in terms of the actual clinical care, in terms of joint replacement surgery, whether they mobilize safely, yes or not. But then if they have to travel to, as you say, Skegness, then we will have to discourage day surgery stuff if they are having to reach there, as you said, midnight, which is not ideal. So we do take a lot of parameters into consideration when we go down to the day surgery route. Clearly, we are trying to improve on that as well. And by making changes and learning from our experience, we will increase the percentage of day surgery joint replacements. However, at present, we have our processes in place to cater for these kind of challenges. Also, after they go home, either day 2 or day 3, the senior sister on the ward, either herself or a nominated deputy, rings these patients up to actually see how they are coping. And then if there are any issues, things are highlighted, and then I'll go on to my next answer, next part of my answer with that. Also, before discharging the patient or based on either day surgery or the next day, they have to be safe on their crutches. They have to be safe mobilization, and they have to have appropriate appliances at home. So the physiotherapist and the occupational therapist have to say yes before the patient goes home. So a lot of parameters have to be ticked before we say patient can go home, either the day surgery or the next day. But clearly, somebody reaching their home at midnight after complex surgery, I completely agree, is not ideal. We would go away from that, and we would rather keep them in hospital for a night more before we send them home the next day. The next part of my answer would be based on follow-up. Again, is something which we discussed in significant and robust detail prior to embarking on these pre-pilot changes. So we operate 2 kinds of waiting list, and there's a reason why I'm mentioning starting from the waiting list, because that will answer to the follow-up as well. So if I see a patient and if I feel that I am the best surgeon to do that procedure, they are listed under my name directly, which means I am the only one who would be doing the operation. However, there are many cases, many types of surgeries where a few of us are able to do it. So what we call pooled lists. We provide pooled lists. So all our patients, all our consultant colleagues put patients onto that list, and they are taken off to give it to a suitable surgeon operating on them. The reason why we started this is because this does influence waiting times. This does influence theatre list utilization, etc. So we, in our department, through our robust clinical governance process, have agreed that whoever operates on the patient will then take over responsibility of this patient, be it on first day post-op, or be it 3 months post-op or 6 months post-op. Now, if something were to happen overnight, then it definitely goes to the on-call surgeon, as I mentioned in one of my answers to the previous questions. But on an elective basis, if there's a follow-up, the surgeon who operated will continue to follow up this patient. Now, reassuringly, we have clinics at various places. So even if the patient, say, for example, your example of the patient living in Skegness had operation at Grantham, they do not need to travel to Grantham for a follow-up. They can see either at Louth or at Pilgrim, depending on where the operating surgeon runs a clinic. And not only the clinic follow-up, but also things like pre-assessment clinics and other clinic visits can be planned around more local hospitals than having to travel to Grantham for all these care. Hopefully that's answered most of your points. If I've missed out anything, please feel free to ask me again. Thank you.
No, thank you. That's very thorough and helpful.
Thank you. Just picking up some of the points that Dr. Wookie's made. You know, he said it's 55 miles that is from Skegness to go over to Grantham. Well, you know, we talk about patient choice and we talk about wanting repatriation back into Lincolnshire by using Grantham as this centre of excellence. However, you know, if you lived in Skegness or, you know, Mablethorpe or wherever, it'd be much, much simpler to just jump in the car and head towards Grimsby. So how are you going to prevent that from happening? Or again, with patient choice, you know, again from Skegness, it would be easier for me to travel over to Peterborough than it would to head over to Grantham, which is a lot more difficult to get to. So some of these, I think, is where this plan in respect doesn't go as far as I think you would hope it will, and I think will cause considerable problems with repatriation. So I was wondering how you feel you can address these points.
Thank you, Chair. We did discuss this again as our business case, pre-business case consultations, and also the reconfiguration as well. The two reasons why we thought we would still gain as a net, because we can't stop people going and choosing Grimsby from Skegness as opposed to coming to Grantham. However, the reasons why we thought we would gain are, one, we prove that we are a centre of excellence at Grantham, and then, as you mentioned, the phrase patient choice, patients can then choose to come will choose to come to Grantham because they get a better care comparatively to other providers. That's one of the reasons why we thought we would gain, but then that's up to us to improve our standards of care. Secondly, what we thought would happen is, whilst people from Skegness go off to Grimsby, there would be an equal, if not hopefully a larger number from closer to Grantham who are going to Nottingham and Marlborough, who might choose to come to Grantham because of the service we provide. So based on these two things, we thought, yes, we would lose some patients, but overall we would gain in a net fashion. Thank you.
Thank you. I've got a number of other speakers to bring in, but just again, it's with transport, it's all good and proper you addressing that, and I know that the County Council has a role to play in the public transport element. I can get from Skegness over to Peterborough without any issue at all, and I can use a bus service to do so. I can't get to Grantham in that manner. And whether or not people are happy to make the journey and willing to make the journey at the moment in time, that's those people that you've had come forward. There are going to be those people that can't, and I still don't think that that is fully addressed. However, I will move on and I'll bring in Councillor Parkin.
Thank you, Chairman. A lot of my points have already been picked up by the speakers, but it's something similar to Councillor Allen's point, but just want to kind of dig a little bit deeper into it. Talking about patients at the moment, in terms of how people are responding and people are not whether they are coming forward into primary care for the knees and the hips, whether there's evidence of people actually really struggling in our communities with these needs unmet because they are so reticent about coming forward, and whether there's any modelling, any idea at all about how that could impact on numbers when those people do feel confident to come forward for care, and whether in fact we will have more patients with greater complexity of need who have been in chronic pain for a long time as a result.
Pete, your hand is up. Do you want to come in?
It was to address the transport question that was raised earlier. I'm not sure if it's difficult to know what the unmet need is out there, but Val, I'm not sure if you've got any feedback that you have.
No, so yes is the simple answer. People are waiting longer because they're forced to wait longer because of other issues. Yes, we as orthopedic surgeons are expecting a group of patients who would require hip and knee replacements, and their surgeries would be more complex than if they had their operation previously. But unfortunately, that's the nature of the beast. I'm afraid we are tackling two big problems, and we have to tackle one bigger problem than the other challenge. In terms of the other issues, I'm sure councillors and chairman would know that we also have an NHS England improvement initiative within the CCGs and the health community that we are carrying on with big MSK kind of changes, pathways and things which are basically centered on two things, where we are streamlining hip and knee replacements and also trying to improve sort of left shift patients' care into the community. And that's a CCG initiative within Lincolnshire. And we are currently having significant discussions, regular discussions about creating these pathways by the CCGs under the direction of NHS EI. And so, yes, we will encourage people to come to us, but then the culture really and the anxiety really is in the community and the patients. But based on the pain, they will obviously, we expect them to come to us at some point, and we can reassure the public that we have restarted our elective orthopedic clinic appointments. So previously we had stopped them, now we have restarted them, and we are beginning to see new referrals coming into us with hip and knee ailments and other joints as well. Thanks.
If I could just come back in on the transport question, if that's the one previously read around Skegness, I think the two noticeable differences, the hospitals reference Grimsby and Peterborough. One, I don't think you'd use for elective orthopaedic surgery, you'd use public transport to get there, because if you're in that, you'd qualify for patient transport because you wouldn't be able to use the car there or back. Peterborough, but both centres, regardless of distance, I think Peterborough about similar distance to Grantham, they also they don't have a split, so they'll be impacted by emergency, the emergency flow coming into the hospital, because both of them have emergency departments on site. So Grimsby were doing so with Peterborough. So the beauty of Grantham is, even if it is relatively longer in terms of the journey time, if you know you're going to be seen quicker because the waiting list times are shorter, and actually you're going to be seen on the day rather than get to Grimsby and then have your day cancelled and come back, the relatively impact of a slightly longer journey time is certainly reduced by having your surgery on the day sooner than you would have done if you'd gone to another centre. And I think that's part of the reason people choose to do it, because I think the key bit is the patients living in pain here want to get back onto their feet or get back to being mobile as they possibly can, and having that surgery as quickly as possible when you know it's going to happen on the day it's planned for has a big impact on what patients choose to do.
Okay, thank you for that, Pete. I now have Councillor Matthews. Oh, you'd like to come back? Yep, sorry, Councillor Parkin.
Councillor Macy, it's not really a question to do with this paper, but listening with real interest. We've clearly got a lot of members of our community who will be struggling in chronic pain, not just because of this, but these kind of health issues, but others. And I just wondered if it would be a suitable area for us to look at some other point in terms of the wider impact of members of our community struggling with these kind of issues, because obviously the impact on mental health, the impact on community nursing, the whole system is going to buckle in the community if we've got these people who are living with these health conditions that they are not seeking support and help for.
Yes, thank you, Councillor Parkin. We'll pick that up in the work programme. So, thank you. Okay, over to Councillor Matthews.
Thank you very much indeed, Chair. And Mr. Sackville, thank you ever so much. What I want to say first, it's clear that you're a brilliant surgeon consultant and you're doing very, very good work in Grantham. So everything I'm going to say is not addressed about the quality of delivery in Grantham, but it is about the factors that affect people who live in Mablethorpe or on the East Coast. On the I Live Here rating for Mablethorpe, it's 10 out of 10 for health deprivation and disability. You have said that you have had no complaints from clients, patients, about having to travel to Grantham. I'm sure that's the case. I'm not challenging you on that. What I can tell you is I have had complaints about the fact that patients have to travel to Grantham. And you've used the phrase, they're willing to travel. And you've said people are willing to travel because they are likely to get the operation. I don't doubt that. What I think is the wrong word there is willing. It's Hobson's choice. We've got a crippled community on the East Coast who have to travel to where they can get the operation. Now, I recognise that that probably is the reality in this world. What I'd like you to do is to understand that in Mablethorpe, and indeed along the East Coast, we have the highest proportion of elderly people within the population, often couples or singles at the, in the twilight of their lives. And this is clearly when these conditions come to take effect on them, so they become quite poorly. I think there is an engagement reluctance. I think there's a culture of anxiety about travelling, and I think that means probably they're not taking up the opportunity to come and have surgery, and that's contributing to poor lifestyle choice here because they're actually worried. I would like you to reassure me that if this goes ahead, you'll provide specialised ambulance transport, not a mini minor or something like that, but something where somebody with a totally reconstructed knee who has to travel for 2 hours and 40 minutes from Grantham to Mablethorpe, if there's a slight bit of traffic, will have a comfortable and journey and be well supported during that journey for their pain. I'd like you to reassure me that there will be support for travel for carers who may wish to go with their partner at this very traumatic period in their lives, and so that they will be able to travel, be able to stay and be accommodated at your centre, be able to travel back with them, because I think that will be a big relief for lots and lots of people. I'd like you to be able to reassure me that there's consistent high quality home support for people who are returning on that 2 hour, let's say it's a 2 hour, 20-minute journey. On that 2 hour, 20-minute journey, arriving back in Mablethorpe in the dark, possibly in the wet, possibly on their own, to their doorstep, having had a reconstructed knee. And I'd like you to reassure me that you'll improve communications with the carers or the partners or the others, because you've talked about if circumstances change during the day, you may hold somebody in overnight, or you might move them from Grantham to Lincoln, or you might move them from Grantham to Boston. That's okay for you, you're in control of those processes. But if there's a carer or an anxious person at home in Mablethorpe or in Skegness, is that communication and that support and the, if you like, the sympathy and the welfare for those carers being provided at the same time as the excellent high quality surgery is being provided? I hope you understand the distinction of what I'm saying. I think this probably is a good plan, but it hasn't got enough wrapped around it to provide the reassurance that those people on the East Coast will be looked after from the beginning of the surgery journey to the end of it, and that their carers and partners and families will be well informed and will also be looked after as well. Thank you.
Thank you, Councillor. I think that's a very good and detailed question. May I start by thanking you for commending us on the clinical care we provide. A couple of clarifications before I go into the reassurances. One is, as I said, I haven't got the complaints. I talked about datixes and incident reporting and things like that, because once that is, then that's how I know it's official, because I will need to investigate them. That's what I meant when I said I haven't received any complaints. I'm sure you meet them more on a regular basis, and I don't deny the fact that they mentioned these concerns to you. And the second reassurance is about willing, the word willing. I'm sorry if I did not come across as I wanted to come across. It's willing, is patient would be willing if we provide the care to the patient, because that is essentially one of the discussions we had prior to the reconfiguration and with the National GIRF Board. And I remember that because I was the one myself in that discussion who actually challenged Professor Briggs about travel and coming back. And then the GIRF recommendations were based on national studies which said if we provide excellent care, patients would be willing to travel. So I'm not saying every person is willing to travel. I think the expectation is people would be willing to travel if we provide them with excellent care. Now going on to the assurances, I agree. In broadly speaking, our communications can be better, and I think it can always continuously be better, and we are learning from our experience, and we continually reflect and continue to improve our processes and pathways. In terms of travel, I have no problems with agreeing with what you asked for. It's not like a mini or small, small transport vehicle. It should be an ambulance, and I think Pete would probably come in on that in terms of patient transport and things like that. And we do think about the patients who have to travel far after their complex surgery as well. In terms of post-care, I'm not talking about clinical care, I'm talking about post-operative support and things. As I mentioned one of the answers previously, a senior sister or a nominal deputy does ring them and keep contact with them in the next days. They have after the operation, and there's any concerns that we always give them what they need to do in terms of information and things like that. There's constant conversation between the three main hospitals and the Louth Hospital, if the surgery especially is done at Louth. Previously, we used to work as 3 different departments, and we had 3 different groups of surgeons. We had 3 different groups of managers. Say the pathways were completely different, and there was difficulty. Now we are working as 1 department, 1 process, 1 pathway, and it's easier to communicate between the people around the different hospitals. So hopefully that would continue to improve, and assurances can be visualized and experienced as we move along. Are we the finished product yet? No, we are not. And I agree with you that that package is not maybe as robust as one would expect in the paper. That's probably because we are continually improving things and learning from our experience. Thank you.
Yeah, just on the patient transport element of that, yeah, carers are supported. So if someone does need a carer, either for mobility or because of they just need support because of vulnerability, then there is an eligibility criteria for carers to have PTS support as well as the patients themselves going in, and obviously they get transported back on the right kind of vehicle depending on what their outcomes are after surgery.
Thank you both. And I'm truly not trying to challenge you two. I'm trying to protect the interests of people who live on the East Coast. There seems to be a slight conflict in that last response. If the patient is in an ambulance, will that ambulance be appropriate transport for the carer as well? Who's also likely to be an elderly person with their own aches and pains and anxieties and could have had a very long day. And secondly, I understand that somebody from your hospital will ring within a matter of weeks to check everything's okay. What I'm particularly worried about is single people or elderly frail couples where somebody comes in an ambulance and is delivered back to home at 11 o'clock in the evening when they've had a fairly grotty day, challenging at the very least. Will the support be there to help somebody get them up the stairs or make sure there's a bed downstairs or they can go to the loo? Will that be in place to enable them to thrive following clearly the excellent operation but the challenging journey? It's those things that I'm worried about.
Thank you, Councillor. As mentioned earlier, patients do not, whether they're day surgery or not, they do not get discharged without appropriate support measures in place. So the ones we expect, so we do expect a lot of mobility challenges after such a major operation, especially in the lower limb joints. And hence we do have a physiotherapy backup. We do have occupational therapy backup. Patients have to attend pre-operative discussions. Prior to COVID, we used to call them hip and knee schools. So the occupational therapists are involved prior to the operation. All these measures are put in place, like raised toilet seats or appropriate chairs and bed downstairs and all these things. All these measures are looked into and sorted prior to the operation to start with, or at least planned prior to the operation. And after the operation, they are not discharged home if these are not in place. So expected problems we do cater for. Now, the phone call is for the unexpected problem. And once that happens, then we give them support, and it happens the next day or the day after. And these unexpected challenges, if the patients have, then we give them advice as to how to tackle or cater those problems. Thank you.
And just on the patient transport question, yes, they would be on the same vehicle, because part of the need for them to qualify would be they'd need to support the patient who's being transported in.
All I can say to you is that the people who write to me and speak to me about their experiences are not painting the same picture in reality of the vision that you're talking about, that post-treatment care. Now, I don't want to forward my email trail to you. I want the reassurance that those promises you're making about community support, will there be a community nurse or whatever they're called now there to help the person out of the ambulance into their bed on that first night? Will that wrapped around care and support be there? Yes, you might have got them a ramp and you might have got them a walker and you might have got them crutches and you might have those things. in reality, it's not happening. It's not happening. And these people are coming back, having had excellent surgery, having been transported, but then they're sort of abandoned into an uncare thing. And I'm not going to come back on this again, but I just want, I've lost you. I just want you to understand that what you're saying is not happening in place along the East Coast from Mablethorpe to Skegness. It may happen on occasions, but it is not consistent and it's not 100%.
Thank you, Councillor. I really can't answer any more than what I've answered. However, I take your concerns on board, and I will speak to my nurse in charge, sister in charge on the Grantham ward, to look into these matters and definitely sort of, if there is a problem, iron it out, and if there is something else which we need to do or we can do, yes, we will look into that and sort it out. But I will certainly carry on with my sort of, so to speak, investigations into the problem and make sure that that is available to all rather than sporadically. Thank you.
Thank you. I'm just conscious of the time. We're already sort of just over where we should be at the moment. So I have 3 more speakers and I have a couple of questions myself, but I am closing the debate down from after that. So Councillor Wootton first, please.
Thank you, Chairman. My question was about transport. Obviously, at Grantham, we welcome any additional services at Grantham, but what it tells me this morning is that I'm listening to problems that we in Grantham have been moaning about for the past 5-6 years, that we have to travel to other hospitals at extreme costs to get there. But my question is, do you accept on page 65 there are a number of groups of people with disabilities, low incomes from deprived areas that have got no cars, that can't get to Grantham Hospital and wouldn't be able to travel? Do you accept that your picture is not as rosy as you project?
No, because they're qualified for patient transport services. So I accept that there are people in that nature, but if you're having orthopaedic surgery, you are qualified for, unless it's day case and you are mobile. But the nature of having surgery suggests that actually you've got an issue with your musculoskeletal side of your body. You can't drive, so you qualify for patient transport services.
No, but it says in your report here that negative impacts of this proposed change on deprived population, including, I can't read, my eyesight's getting bad here, including travel requirements. So it has been highlighted to you. I mean, I wouldn't like to live in Skegness and try and get to Grantham. You must need overnight accommodation, bed and breakfast.
So there's 2 elements to that extent. So if people choose to travel for using their own car, clearly it's going to be more expensive to travel further to Grantham than it would have been if it was Boston originally, in that sense. So it's that, in that kind of anomaly, that's the difference. The main difference, though, also, if you had that operation cancelled, you might be doing that journey 2 or 3 times to Boston Hospital, at which point it is negated. But it's clear that yes, we're aware that the deprivation is on the East Coast. And therefore asking people to travel long if they're travelling in their own car, because most people would rather have their own transport because obviously they're used to it and they're on their own, it's direct. It does cost more to get to Grantham. That is the reality of the situation, unfortunately.
Thank you, Chair.
Thank you, Councillor Wootton. I've got Councillor Woodliff.
Thank you, Chairman. Mr. Sackville, is it? Have I got it right?
That's
good morning, sir. Good morning, sir. Sorry about mispronouncing your name. I have that problem with people mispronouncing
That's okay.
mine.
No worries. Carry on, please. Sackville, yes.
It's life, isn't it? Well, my wife received replacement hip treatment in 2015 at Pilgrim Hospital, and the care was excellent. And January of this year, she had to have an emergency procedure because the hip popped out. And again, it was dealt with at Pilgrim, and it was excellent. And from my experience, from what I understand, Pilgrim was the #1 hospital for doing hip surgery around about 2015 and maybe up to 2020, #1 in the country, I think. And so the service provided there was outstanding. I think my question really is, with this new hub at Grantham, and I understand the logic of all this, there's a logic that you concentrate major operations at certain hubs, might be stroke, so on, hip replacement. And I can understand the reasoning behind it, but can you guarantee that the service that we will receive from, say, Grantham, will be of the same standard that my wife received at Pilgrim Hospital? And I think it was 2015. I had to check with her just now on the phone. It was 2015. The standard there was very, very good. It was outstanding. Will the standard be as good at Grantham? That's the question. Oh, and there's a second question, because I'm allowed two. Second one is, what's the current staffing situation across ULHT for consultants? In some areas, of course, ULHT suffers from significant shortfalls of consultants. What's the situation across the county? Is Grantham going to take all the top people so that, if a major emergency occurs, Pilgrim won't have so many of the top people? Or is the situation reasonably flexible across ULHT to ensure that if an emergency arises, the standard at Pilgrim Hospital will be as outstanding as it has been in the past? They're my questions, really. So, first of all, thank you very much indeed for the service that you provided up to now. Will it be as good in the future? Thank you, sir.
Thank you, Councillor. Thank you. Again, let me start by thanking you for your commendations about our service at Pilgrim. And I'm glad that your wife did have a good experience on both occasions. Small clarification, when you say about Pilgrim being the best in the country, I'll be very happy if it is the case. My understanding is Pilgrim was the best for neck of femur treatment. So when people break the neck of femurs, which is the hip fracture, that's when they excelled in their terms of treatment. And now I don't know if that's the situation with your good wife, but essentially the treatment was excellent in managing neck of femur or hip fractures. We're talking about elective hip replacements, knee replacements. As I told you in the presentation already, that parameters, various metrics are significantly better at the moment from 2018 in Grantham. So the quality of care, would it be good? We do have to assess that using various metrics, and the various metrics I presented to you in the presentation and in the paper, the results do show that the care is brilliant at Grantham. Now, I'm not here to compare with Pilgrim and say this is better than Pilgrim, but I can tell you that the parameters tell us that the service is heading in one way, and that is it improving significantly. In terms of consultants, I can tell you about consultants and about other clinical staff. Prior to the reconfiguration, we were struggling to recruit into the middle tier doctors who are also called the staff grade or associate specialist doctors. We, after the reconfiguration, for 2 jobs, we've had 74 applications. For consultant jobs, we had to advertise now because of retirements. For shoulder job, we have 15 applicants for a shoulder job, and the interview process is early January at the moment. So in terms of recruitment, we have seen and noticed significant changes, improvement in terms of that process. In terms of questions as to whether all the good or the specialized surgeons would be working at Grantham and leaving the trauma patients alone in Pilgrim and Lincoln, that is not the case. As I told you before, we now work as one department, and we have better communications between us within that department, and all consultants are based at Pilgrim and Lincoln on the 2 on-call hot rotas. So they have their own timetable when they would be doing planned care treatment at Grantham. They have their own timetable when they would be doing unplanned care at either Pilgrim or at Lincoln. So it's not a question of you need complex hip replacement and the hip replacement surgeon is not available to treat you. No, it's not the case. Secondly, we do also see subspecialization. So if somebody comes to me with a problem and I find out the problem is actually B, not A, and to solve B, my colleague is better than me, I just pick up the phone and contact that person, colleague, and say, can you take over the patient? And they take over the patient and so on. So we always give the patient the best surgeon to provide the best treatment. And by doing this, that hasn't changed. In fact, it's better because their job plans are planned accordingly, where they would be in Grantham on a specific day, they would be on the hot site on another specific day. Thank you.
Well, thank you, sir. Thank you for the explanation. I think at the end of the day, if they say the quality of care is paramount, I accept all the comments my colleagues have made about transport. Transport is a massive problem for Lincolnshire. The roads are terrible. The railways are pretty, what can I say, variable. But if you get good quality care, first-class care, I think people will put up with the others. It just is to ensure that the service provided is first class in every respect. And if you can guarantee that to the people of Lincolnshire, then you'll be very highly regarded and greatly thanked, I think. That's what I've got to say. Thank you very much, sir. Thank you, Chairman.
Thank you, sir. Thank you.
Thank you. I've got Councillor Smith very briefly.
Thank you, Chairman. It goes back to the previous point. Certainly when I had my operation in Nottingham, the surgery, and I'm still under my consultant after a lot of argument, was fantastic. The issue was that often Nottingham cannot communicate internally through its systems with Lincolnshire, and my assistance with physiotherapy was non-existent. I'll be blunt, I was supposed to see a physiotherapy every 2 weeks. I saw them twice in the entirety of the time I was supposed to see them. So there is an issue of quality of care after the fact. I had huge help from my mother, who at the time had one leg, so you can imagine trying to lift 12 odd stone of me in gaiters was very difficult. And I'd also go back to the previous councillor, deprivation isn't just on the East Coast, as I'm sure he's aware, and certainly in my division, we have no option. Wherever we go, we have to travel because the nearest hospital is Louth, and unfortunately, a lot of the services aren't there for rationale reasons. And one very brief question, if I may, Chairman. In terms of getting people back from outside of county, how many, even with this pilot, do you think will still elect to, say, for example, travel to Nottingham? Because as previous councillors have said, in my case, it's far easier for me directly to travel to Nottingham than it is to go to Grantham.
So, thank you, Councillor, for the question. Now, as we highlighted in our responses to various questions, we really can't stop people from travelling to other areas to get their treatment. As we all know, it's patient choice. What we're trying to do here is to showcase our services. And as the previous councillor mentioned, quality of care. We plan to showcase our quality of care improvement. And rather than, force you to come to us, which I'm not saying we will, but rather than doing that, we want to encourage you to come to us. And you might feel that the quality of care at Grantham surpasses the quality of care at, I don't know, for the neighbouring provider, let's say. And so you might choose to come to us. And that is what we are banking on. We are banking on you to choose to come to us. And also, the other issue about communicating is, I'm sure you know this more than I, the communication between two different health economies is difficult, whereas communication within the same health economy is far, far better as a clinician. Thank you.
Thank you. I think we had a bit of a problem there where it dropped out for a second, but thank you. Okay, I've just got two questions. And then I'm going to bring this to a closure. So my first question is, how does the confirmation of funding of £5 million for the 2 new laminar flow theatres affect this proposal? In the light of paragraph 9.2.53 on page 59, which refers to the need for one more theatre. And I'll ask my second question after, if I may.
So in terms of the extra theatre capacity, because of Grantham generally being a green site for other issues and other specialities as well, the theatres are now being used for other subspecialties like cancer surgery, breast, urology, etc. So we now, because of our increased ramp up of of 7-day working, and especially weekend working, we do need these extra theatres to provide with our patient backlog at the moment. And that is why we anticipate this extra theatres would help us. And it has to be laminar flow because it gives us the chance to do joint replacement surgery in such theatres. Again, talks are ongoing at the moment about these extra modular theatres, and it will help with the catching up with the backlog of elective orthopedic activity. Thanks.
Thank you. And following on from that, the additional beds and the extra 2.5 theatre space is out of scope on the current business case currently. If this doesn't progress, how will this affect the repatriation of patients from private or neighbouring trusts, and how fundamentally will this affect the plan?
The plan would be obviously the catering to the extra patients being repatriated back into the community does rely on extra operating capacity, although there is operating capacity where we could absorb space elsewhere, like in Louth, for example, and Pilgrim and Lincoln. However, the challenges are different in each spaces, and it's much more difficult, and it would have a negative influence slightly on other specialities who require their services at Pilgrim and at Lincoln based on the support services post-operatively, which we don't want to do. So yes, it would influence, but we hope it won't come to that. And that's what I'm trying to say. Pete?
Yeah, it's just to highlight that there, in the pre-consultation business case, there is another stage to the orthopaedic, to the actual general surgery element of that business case, which we're not taking forward because the capital isn't there. So what we are consulting on here, it can be delivered within the current capacity. What we'd like to do is gain further capital funding to run a consultation on general surgery in a greater depth, but that does need the work. And the reason we haven't moved that forward is because that capital isn't available. So these services, these proposals, all 4 proposals, the money is in place, and the only one that needs capital at this stage is stroke. And as this is really a proposal on making the pilot permanent, and that's been proven to operate as it has, because it operates since 2018.
Okay, thank you. In which case, I'm now going to move to a proposal. So I propose that we note the details presented on the Lincolnshire Acute Services Review of Orthopaedic Surgery, that we record the committee's initial findings on the proposal for consideration by the committee's working group, and I'm sure we've highlighted many areas which the committee's working group might wish to look at in further detail. Do I have a seconder for my proposal, please? Councillor Linda Wotton, thank you. All those in favour, please show. Thank you, that's supported, and thank you very much, Pete and Mr. Scribble, much appreciated. We'll now move on to agenda item 6, the Lincolnshire Acute Services Review, acute medical beds at Grantham Hospital. Okay, and that's on pages 73 to 104 of the agenda pack. And I'd like to welcome our presenters by teams, Dr. Dave Baker for South West Lincolnshire Local Clinical Lead and Lincolnshire Clinical Commissioning Group, and Dr. Yvonne Owen, Medical Director for the Lincolnshire Community Health Services NHS Trust, and once again, Pete Burnett, System Strategy and Planning Director. If I can hand over to you for roughly a 10-minute walk through it, and we'll take questions at the end, please. Thank you.
Do you want me to start? Okay.
Yeah, please do.
Yeah, I'm just checking. Can you hear me this time? Because we had a little bit of technical trouble when I came to the previous committee meeting. So can you hear me okay this time?
Unfortunately, no, it's still not great, but we'll clamber through as best we can.
Okay. So I'll be relatively brief because I think that will give time for more questions. As with the A&E, I think it's fair to say that there have been recruitment issues with the provision of acute medical beds at Grantham. And I think the overall uncertainty that's dogged Grantham for many years has clearly added to that. We've got other issues such as rising demand for services. And I think there's also recognition amongst the clinicians there that there are some patients that currently come to Grantham that actually, because of the severity of their condition, they would probably be better going straight to other hospitals that have got a broader range of services, in particular critical care services. So in line with changes that we're proposing to A&E, it's sensible to change the criteria a little bit for the medical beds as well at Grantham. The other thing I think is well recognised is, and this is across all hospitals really, I think there's a lack of integration between what's provided in the acute setting and primary and community services. In terms of the feedback we got from the people of Grantham, they clearly want local services where possible, and they certainly raised the issue of travelling time if they wouldn't be able to continue to receive medical care at Grantham. So certainly retaining beds at Grantham would reduce any additional pressure on the ambulance service. Now, in terms of what we currently have, we have something called same-day emergency care, where patients are assessed on the day, and many of them are actually investigated and discharged on that same day. And we have 3 medical wards as well at Grantham. So the proposal here is that we would retain those services. So we'll retain the same-day emergency care services, we'll retain the medical beds. There'll be no reduction at all in the actual bed numbers, but we are looking at a more integrated service. So currently the beds are provided by ULHT. We're looking now at a partnership approach between ULHT and the community provider to provide that service overall. The service would still be consultant-led as it is now. So the main change really is that those that are most seriously ill, so around 10%, would go to other hospitals that have got that backup of services such as critical care. So the vast majority of people would still get their care locally. The other big advantage, I think, is that integration that we would hope to see between community services and the teams at the hospital. And I think that's really going to provide much better care for frail elderly patients in particular. We're also looking to introduce a brand new frailty service where GPs and community teams can actually arrange for patients to come in for the day or for a couple of days, get all their investigations done together, and then hopefully back out into the community as quickly as they possibly can, rather than an acute admission, which is what often happens now. So the idea really is to keep as many people out of hospital where it's safe and sensible to do so. And if they do, unfortunately, have to come in for an inpatient stay, we get them out again more quickly with better community support. So I'm hoping this proposal is probably one of the least contentious ones in the acute services review, and we're certainly happy to take any questions.
Okay, thank you. Start with Councillor Ray Wotton, please.
Yes, thank you very much indeed, Mr. Chairman. If I could refer you back to our last meeting, where we read in the papers, it's a question to Dr. Baker, really. Good morning, Dr. Baker. Regarding the term UTC Plus. Now, I asked Dr. Baker this at the consultation event the other night in Grantham, and he said there's no such nationally defined services as a UTC Plus. But when I read my reply, which I got back, it goes on to say, we recognise that clinical colleagues often refer to this name in recognition of the proposed model offered an enhanced service to the UTC national specification. So it appears to me there's going to be additional facilities at Grantham more than the national UTC. So could you just give us some clarification, Dave, this morning on what those are? Thank you.
Yes, I can, Ray. So a UTC would normally see patients that have a level of acuity. We use something called the National Early Warning Score. It's called NEWS. And UTCs would normally only accept patients by ambulance if their NEWS score is 3 or below. Grantham, the proposal for Grantham is that they would accept patients with a NEWS score of up to 6. And indeed, patients who, for example, have care plans where they wouldn't be perhaps for critical care type escalation, we would also be able to take patients with a NEWS score higher than 6. So it's quite a significant increase in what you would typically see in an urgent treatment centre. The other thing that Grantham fortunately has the benefit of is not only obviously access to bloods and x-rays, which you would see in most, well, in all urgent treatment centres, but we've also got other facilities such as MRI scanning and CT scanning. Now, because the model for Grantham would also include A&E doctors and consultant support, then there is no reason why those higher trained doctors would not be able to, where appropriate, order a CT scan, for example. Now, clearly that's not going to happen at many of our other UTCs because they just don't have access to that level of diagnostics. And that's why you'll remember, Ray, that when we looked at the activity that currently goes through Grantham A&E, around 97% of those patients would still be able to come to a UTC if that were the proposal that we went forward with. In terms of the plus, it's really that we wouldn't be allowed to use that kind of nomenclature. So you can't call something a UTC plus because there just isn't a national specification for that. And we have to fit with the NHS guidance that you designate things as A&Es, things like A&E, type 1 A&Es or urgent treatment centres, but we wouldn't be able to put a plus at the end of it. So I hope that answers your questions, Ray.
Chairman, so Dr. Eggleston, why was it in the paper as a UTC plus? Obviously, so either somebody made a mistake or they got it wrong.
I wasn't aware that plus was in the paper, but if that's the case, then that is an error on whoever wrote the paper. But I wasn't aware that was in the paper.
Thank you, Chairman.
Just quickly on that point, the paper actually articulates on page 81, 10.3.3, that the East Midlands Clinical Senate recommendation, other than not to use the term UTC plus. So it is in there, but it's the only term it's referenced, and it's in not using that as a reference point.
Okay, thank you for clarification there. One thing that does concern me, and when you use this terminology, whatever way you want to say, whether it's in the paper or not, you are going to offer more than what a UTC currently does in Grantham. My huge concern is it's okay saying that now, but also what can then the residents do if you begin to erode it back to the basic offer of a UTC? And I think that sometimes that could possibly be seen by the residents. I'm not saying it's meant to be, but as disingenuous. I haven't got any other speakers currently. Councillor Smith.
Sorry, Chair. On page 77 in the Acute Services Review, it quotes a figure of 10%. What is that in numerical numbers? And also, why is there such a recruitment issue within acute medicine? Because reading through the paper, it's quite alarming, the recruitment issue that's there. I know there's an issue across the piece in the NHS, but the severity in that particular department is quite a concern to a layman looking in, and I can imagine if the public read that, they'd be quite horrified.
Pete may have the exact figure. I think the figure is around 300 patients a year. Pete will be able to correct me if that's not true, but I think it's certainly close to that figure. In terms of recruitment, it's a problem nationally, actually, for medical consultants, particularly acute medicine consultants. The medical rotations are generally made up of all the myriad of different specialists. So, respiratory healthcare for the elderly, gastroenterology, and acute medicine consultants. But it is a national issue. I think Grantham has clearly been plagued by the uncertainty, though. If you don't know if you're going to have a job there in 2 years' time because you don't know if there's going to be medicine provided there, is it the place you would apply to do your job? Probably not. So I think having that certainty will help. And I think the other thing for me is that because it's going to be quite a different model, particularly in how we look after frail elderly and how we integrate with the community, we actually think this could be very, very attractive to people who want a slightly different experience from what you typically see in a large hospital in terms of the acute medicine there. And certainly when we presented this to the clinical senate, that was their view as well, that they thought this is quite an innovative model. Hasn't really been done anywhere else actually, and we think it will be attractive, perhaps to a different breed of consultant who want a different experience. Yvonne, I don't know whether you want to add to that at all.
Yeah, I would really echo what you're saying, David. I think that there is a lot about the model that's being proposed that would be attractive to consultant physicians, and because of the greater integration with the community, I suppose in some ways we would be less reliant on the number of consultants and therefore less at risk of potentially losing services and the ability to admit patients because of difficulty in recruitment. So in general, we feel this is a much more attractive model which should help not only recruitment, but I suppose more importantly, maintenance of our medical staff when they are in post.
Just to confirm, that figure is 385 per year, so just over one a day, which is the 10% figure quoted. And just also to confirm that the services we're consulting now have got a 5-year trajectory in terms of that's what the business case is predicated on. So we wouldn't be looking to, the aim is that these services will be in place for the next 5 years.
Thank you. Coming back to what was mentioned, what does 2 points? What does a different experience equate to for a consultant? I appreciate you might not be able to answer that. And secondly, how do you combat? It's probably a very old-fashioned way of thinking, but how do you combat when a lot of people, when you say care in the community, the first thing that a member of the public, or quite often a member of the public, will say to me is that's care on the cheap. How do you combat that? Because I appreciate that often isn't the case, but that is going to take some dissuading, which we are going to, not just ourselves, but also working with you. How do we together get away from the care in the community equates to care on the cheap?
I think in terms of care in the community and the cheap, it's probably quite the reverse actually, because it's often more efficient in a way, isn't it, to provide. If you've got a ward full of people, you can put all the therapists into the same place. There's no travelling between different houses, so it's often perceived as perhaps more efficient to actually put it into a ward. So I certainly don't think it's cheaper. But the thing for me is we know patients want to be cared for at home where at all possible. Everyone's got a bed. That's the best bed that they should be in, really, rather than a hospital. So I think if that's what, particularly our older patients, if that's what they really would want, we should do our very best to do that. So it's certainly not on the cheap. In terms of different experience, one of the things we're looking at is having those consultants actually support the wider community team. So, for example, if we've got a respiratory consultant, they will see, they'll obviously be able to see patients within the hospital and provide the outpatient services that you typically see. But we've actually got lots of community respiratory nurses across our county. Now, those consultants will be able to provide telephone, video, remote advice to those broader teams. So it's a very, very different thing that we're looking to do. And the idea of that is that rather than bringing the patients in to be assessed in hospital, you've got consultant advice, 7 days a week, essentially, to our respiratory nurses who are they're specialists in their own right. But I think with that advice, we'll be able to keep many, many more people out of hospital. And the other thing is not just in the Grantham area, because clearly these consultants could provide advice to community teams across our county. So that potentially could then reduce pressure on Lincoln and Boston. So, that's just a flavour of how there's a different experience for a consultant who, in all honesty, if I was a respiratory consultant, I could work in Nottingham or Lincoln and have quite frankly, a very, very stressful and busy job, I could actually have a very different experience with Grantham. I think it won't be as busy, but I think it'll be rewarding in its own way, in a very different way. So there will be some consultants that actually is attractive to.
Okay, thank you. I've now got Ray Wotton coming back first. Thank you.
Thank you for allowing me to come back, Mr. Chairman. Dr. Baker, on Sunday's consultation, I was extremely disappointed that the staff there outnumbered the members of the public. I mean, there was 15 staff and 11 members of the public, and myself and Linda were two councillors that were there, and there's other councillors there. But do you think it's apathy that that's been drawn in, or do you think the people are fed up with it, or know that whatever their view is not going to be listened to, or the fact that you've made your mind up and that's it?
That was hard to say, Ray. The event was advertised quite widely, and I'm sure Charlie will be able to give you the details as to how it was advertised. I think we had between 30 and 40 people that registered to attend, and unfortunately less than half that number attended. I think you're possibly right in some of what you say, that many of the public will think, you know, it's sort of preordained, but you know, I think we are genuinely doing a full consultation exercise and trying to gather as many views as possible. And certainly, if as a result of that exercise, we need to look at changes to the proposals, then we'll absolutely do that. That's what we're committed to do.
Yeah, it's just going to build on that, Dave. In terms of, there were 30 to 40 people booked in. It's difficult to know why they decided not to attend on the day of the event. It had been publicised in the Grantham Journal. There'd been also, I think, it had another publication not led by us in the Village Link magazine, and we'd publicised it on Facebook, had the kind of the SOS Grantham campaign group. So I think for all our, and Charlie will come in, but for all our kind of different social network, we've had paid for advertising. People knew about the event. It's difficult to comment on why they've chosen not to attend.
Chairman, if I could just ask one more question. Do you have a total number of feedback forms that have been completed, or total number of responses that you've had from members of the public to date?
Yeah, just before you respond to that, I was just going to say, right, we've already got Dr. Owen that had wanted to respond to your question, and Charlie Blythe. So if you can answer and then come back to the secondary question, please.
Yeah, thank you. I just wanted to add, I suppose, you know, working in healthcare at the moment, I think that there is quite a fear of the new Omicron variant, and I think it's quite likely that some of the people who had booked to come to Sunday afternoon's event will have just been scared. They probably won't have had their booster jab yet. And certainly, you know, the impression that I'm getting from patients is they are being much more careful in terms of attending public events. So that's why it is particularly important to encourage people to complete the feedback forms that can be done remotely. So that if they choose not to come to these face-to-face events, at least they still have the opportunity to comment. Thank you.
Thanks. I'll just come in, Chair. Obviously, a lot of what I would describe has been said. I think Yvonne's point is really important there, that this coincided with a resurgence and a lot of national publicity about COVID. And so we know that will have an impact. We know the fact that Sunday was a relatively sunny day actually will have had an impact to some people who didn't want to spend 2 till 4 o'clock in a Sunday afternoon in a hall. So matters like that do impact it. In terms of promotion, we did quite significant advertorial in the Grantham Journal just prior to it. If there's one place in the county that we rarely struggle actually to get attendance and people there at the moment, it's around this particular issue in Grantham. So I think the COVID measures are a really significant impact there. But one other thing I'd just add is it's not just these events that are important with the consultation. Yvonne's just mentioned the questionnaire, but we're doing a lot of individual discussions. We've got a lot of contact with people coming to us direct for clarity and wanting to understand their issues. Not everybody likes to speak in a public event, and so there are a number of measures that we have to manage that. We've got focus groups happening, we've got telephone surveys to make sure that we reach a wide selection of the public as well. So whilst it's always disappointing when we're putting events on, and we do get certainly a lot less attend. We had 12 attend, and as you know, we were well into our 30s in terms of people that were registered. It's always disappointing. These aren't the only activities that are supporting the consultation and making sure we're getting the information out to the public. So just wanted to note that as well. Thank you.
Charlie, do you have an estimate of how much feedback you've had from the members of the public to date?
Yeah, so I don't have an absolutely accurate figure, Councillor Wotton, and actually we're loath to kind of do that tally, because we're really keen to push that message about it's the quality and the information and the suggestions that come through. But we know we're well into the 2000s now. We always, which is a nice level. We do know, you'll be aware, we've got an independent analysis company looking at it, and they are commenting on the volume of responses that we've had is pretty significant in their experience, and this is what they do. So we know we have reached a lot of people. We know that we're still getting, in terms of our kind of hotspot areas, we've got a high response rate from Grantham, but we have got good coverage from elsewhere across the county. So in terms of the amount of people that we've reached and have responded via the questionnaire, we've got a strong response rate. And so we'll just continue to push that until 23rd of December.
Thank you. Dr. Wookey.
Thanks, Chairman. Brian Wookey, Healthwatch. Just coming on from what's just been discussed, the paper that's come around can make this programme look extremely complex. I just wonder whether, in fact, for the wider circulation, you have a document which is more easily readable and in fact takes in more and perhaps explains what's behind the scheme in the first place, etc. Because, I mean, it is a brave and enterprising scheme. I think everybody would agree. We've had a year or two now to digest it. But there are big changes there, both in management and in delivery, that people have got to digest. But I have to say, I mean, I've been looking at documents like this for years, but you have to read it a couple of times to actually realise it's not quite as complex, the running of the organisation and the new proposals with the UTC, etc., and the acute beds, as it seems at first sight. So I think there's perhaps a bit more selling to do, and if I don't know whether the few people who came, it probably was Omicron, but it could also have been that people had sort of got overloaded with all the other NHS woes that are going on at the moment and found it very difficult to turn out for something like that. That's the first comment, which I would really welcome some comments from you. The other thing is that you've talked about the community around Grantham, and that the community hospital pathway is lacking in southwest Lincolnshire, which I think we know, and this hopefully might be a way of lighting it up a bit. And you talk about primary care and GPs are going to be involved from the start, but you don't say really how that involvement is going to take place, whether it is a sort of referral involvement, or are GPs and primary care, perhaps other primary care staff, going to be involved actually in the care of the patients in the hospital or not. And, you know, that sounds a real opportunity, but I wonder also whether that opportunity, with everybody else and GPs being bogged down, whether they're actually in a mood at the moment to take up that opportunity, because it seems to me that it's something 30 years ago, I would have been really keen to get involved with. And the last is just a matter of detail. You talk about patients whose assessment is such when they come in, but you don't talk about how you deal with patients whose assessments change, and particularly if they change for the worse. You talk about them having to go either to Lincoln or Pilgrim, but that is quite a disruptive business, and I wonder whether there are patients on the borderline who you might decide they're better off to go to the bigger hospitals in the first place. But that's a question of detail. But your comments, I think we would, as an organisation, would like to know your comments on those other issues. Thanks.
Thank you, Charlie.
I'm going to come in on the first part of that and then pass over to colleagues on the second and third. Regarding the content and complexity, absolutely agree. So you'll already all be aware that there are some formalities and some requirements within public consultation that we absolutely have to meet. So one of those is about making sure that we are informing members of the public so that they can respond appropriately for them. And that can be very difficult when different people within that group want to hear a different level of information and already have a different level of understanding. So we have put it into tiers essentially. And so we have our at a glance information, which is typically what one would see on our pull-up banners at the events and in our social media posts, etc. We have what we describe as our key information document, which is a 1 page per proposal with a bit of information up front, which is just giving people enough really for them to understand the context and the facts around it. We then have our consultation document, which is a much fuller version of that. And all of those three that I've just described are printed. And then we also have our business case, which is the complex information which the paper in front of you is derived from. So that business case is very detailed, very factual, and it's the information that went through the NHS EI review process as well. So clearly has to go into a lot of detail and background around it. And it's the basis of our information, but we try and then translate that essentially into public-facing information for the aforementioned items that I described. And then finally, we've got our website, which is essentially where you can delve in more and more layers, deeper and deeper as you so wish, and is the area that obviously being online, we can continuously update. And then we back that up with the information we put out to press and so on as well to make sure it's always contemporaneous. With regard to how we're working to make sure that the right people get the right information, I think a really relevant point is how we've worked with Healthwatch. So some members of your team that we work with quite consistently have been excellent in terms of taking those materials and pushing them out to the appropriate groups. And we replicate that a lot with our partners. And our role is just to make sure that the right type of information is available to partners to be able to do that. But we absolutely recognise the complexity of this information. We need to be able to inform the public accurately, fully and clearly, and sometimes doing all three of those can be really challenging, but that's why we've got different levels that will come in. But I do acknowledge that what you have in front of you is potentially the most complex of what we have. Really, it's that business case information that it's been derived from. So the public facing materials largely are very different to that. Thank you.
Can some comments about the rest of what I've said? Yeah, thank you.
Oh, sorry, Yvonne, you've got your hand up.
Yeah, I just wanted to touch on the GP involvement. I mean, obviously, we acknowledge that GPs are very busy. In fact, David and I are actually doing this meeting from our surgeries. So we won't be expecting GPs to come in and look after their own patients. That was certainly something that at the first part of my career I used to do in my local cottage hospital, and you know, patients loved it, and I think it certainly enhanced patient care. But we recognise that that GPs have got far too much workload already to expect them to come in and take part in ward rounds, etc. David mentioned earlier the frailty assessment service that we will be looking to set up, and that will give GPs the opportunity, if they have patients who are just really complex, they're starting to decompensate, starting to deteriorate, they don't need to be admitted to hospital, but we would like to get some bloods done, maybe some x-rays, we'd like a physio to see them, maybe a pharmacist to do a medication review. We want to do that quickly, we want to get the answers from that so that we can optimise patient care as much as possible to avoid further deterioration. Now, it is incredibly difficult, if not impossible, to get that sort of thing done at the moment. And a lot of these patients do deteriorate and end up in a hospital bed. So that will give the opportunity for GPs to manage that type of patient in a much more effective way, and as part of a team with the multidisciplinary professionals that are in the hospital. Because the hospital will be using the same clinical software as GPs, so if a patient is admitted, and certainly all of the GPs in Grantham are on System 1, the team in the hospital will have direct access to the patient record, and vice versa. The GP will have direct access to what's happening within the hospital. So we would anticipate and expect that communication will be much better than it currently is when a patient is admitted to an acute hospital bed. Thank you.
If I can just come in on the last point that Dr. Wookie mentioned, clearly some patients will deteriorate when they arrive at hospital and need transfer. What we did though, we did quite an extensive piece of work, in fact Yvonne was involved as well, where we looked at patients presenting new score, and we then followed what happened to those patients. And that was the reason we actually picked this new score of 6. Because we found that those with a new score higher than that were much more likely to require transfer for critical care services, and actually the numbers who would require that with a new score of 6 or below was actually extremely small. So while we still accept that there will be patients who come in with a lower acuity score who will then deteriorate, there will be those patients, but we believe that the numbers who will need transfer will be extremely small. And if you set the bar too low, it would actually mean lots and lots of patients unnecessarily being taken to an acute hospital where they never required that level of care. So we've picked the figure quite deliberately.
Yeah, thank you.
Thank you, Dr. Wookie. I've got Councillor White.
Yes, I'd just like to make a comment about percentages. We seem to get presented with percentages quite often, and I think they're just meaningless without numbers. And so if you look at that table on page 78, we don't know how many people responded in either of the workshops. We have no detail of the workshops, and I would suggest that we should have numbers, and if you wanted to add more detail, they could go in an appendix. Thank you.
Just quickly to respond to that, those numbers are detailed in the pre-consultation business case, and I think that's trying to get the balance right between how much information you put in there and how much you don't in that sense. So the pre-consultation business case has all the figures that the percentages aligned to it, like the 10% figure in terms of those who wouldn't go into acute medical beds now. That's in the detail actual element of the PCBC that is included in the papers. I know that's a difference, but it's just getting the balance right.
Okay, thank you. I haven't got any other speakers, so I'll just have a couple of questions myself, and I'll do them one at a time if I may. So, could this proposal be expressed in simple terms as the provision of 69 inpatient beds at Grantham, about 2/3 medical and 1/3 community, instead of the existing 79 medical beds?
I don't think they can, because you'll have consultants potentially working across both the sort of more acute side of it and the less acute side of it. So all of these people will be under consultant support. So I don't think they're community. For me, a community bed would be more of a sort of GP run bed. These are consultant led beds. So no, I don't think they could be expressed in that way.
Okay, thank you. My second question is, under the proposal, would patients be admitted from the proposed UTC to the proposed medical/community beds, for example, after arriving by ambulance?
Yes.
Fantastic.
Simple answer.
Thank you. Brilliant. Okay, in which case, I'm going to move to the proposals, and I propose that we note the details presented on the Lincolnshire Acute Services Review of acute medical beds at Grantham and District Hospital, to record the committee's initial findings on the proposal for consideration by the committee's working group. I think we've highlighted some areas which the committee's working group might wish to explore in further detail, and I'd like to move that to the proposal. Seconded by Councillor Wootton. All those in favour, please show. Thank you. That's supported. That just leaves to thank our presenters. Thank you very much for attending, and wish you a Merry Christmas. Thank you. We'll now move on to agenda item 7, the Humber Acute Services Programme update. You'll find this on pages 105 to 134 of the report back, and I would like to welcome our presenters via Teams: Ivan McConnell, Programme Director; Claire Hanson, Programme Director, Interim Clinical Plan; Lindsay Cunningham, Associate Director for Communication and Engagement; and Stephen Courtney, Partnership and Stakeholder Engagement Manager. If I can hand over to you for around about 10 minutes just to run through it, if you will, and we'll take questions at the end. Thank you.
Yeah, thank you, Chair. We've prepared some slides which I'm hopeful Stephen will manage to share, but just thank you very much, members, for the opportunity to come and talk to you about the Humber Acute Services Programme. This is the first time that we will be presenting to the committee. It really is to give you an overview as to the status of where we are as a programme, but given your role within reviewing the engagement piece, to go on, Stephen.
Sorry, I'm unable to share the slides at the moment. I don't have the permission there.
Okay.
Okay, that's just
Okay.
changed.
We'll continue to carry on. To give you an overview of the engagement work we've done and to outline the next steps. The Humber Acute Services Review is 3 programmes. One which Claire is leading around the interim clinical plan, which we're not here to talk about today, and programme 2 and 3. Now, programme 2 is about core service change across urgent emergency care, maternity, neonatal, paediatrics, planned care, and a major capital programme, which is a £720 million investment subject to ministerial approval, looking at the rebuild of Scunthorpe Hospital, Diana, Princess of Wales and Grimsby, and also some investment within Hull Royal. So next slide, please, Stephen. We were really kind. Thank you. I think it's important to note that those programmes are interdependent. We are part of a national programme, and we're in a process of pulling together a pre-consultation business case for the core hospital service change. That business case will identify multiple options for the potential ways forward and align to the capital investment. And we know that one will not be approved without the other and vice versa. So I think really, really important that members are aware of that. But as we go through this process, we will make sure that we're fully engaging, and we will be going to hopefully a public consultation the middle of next year, post the local government elections. So we're in the stages of working through potential models. We're doing quite a lot of data analysis. We've done a lot of engagement. And the purpose of today was really to give members that overview in a bit more depth around the engagement that we've done. So what I'd propose, Chair, is we move on to that overview and allow committee members, if possible, to then have their questions as you set out. So, Lindsay.
Thank you very much, Ivan. Good afternoon, members. My name is Lindsay Cunningham and I am the Communications and Engagement Lead on the Humber Acute Services Programme. Now, I've got a few slides today, but I'm going to try and rattle through them as quickly as I can so that you've got plenty of opportunity to ask us questions. The report that we sent ahead, which hopefully you've had a chance to read, has a number of background reports attached to it. And that is where we've got them completed, the survey and engagement responses to each of the pieces of pre-consultation engagement that we've undertaken. I just wanted to give you a little bit of a flavour of some of that today. So if we can just flick onto the next slide, please, Stephen. So earlier this year, in the spring, so we began in February and completed this engagement exercise in June. We undertook an engagement called What Matters to You, and this was to support us in developing our evaluation framework. So in terms of understanding different priorities and preferences of our different populations across the Humber, but also in the areas that feed into our hospitals. The statements that you can see on the slide there, we co-produced those with our citizens panel. They're a group of around about 20 individuals who live across the Humber region, represent different groups such as carers, BAME populations, as well as other voluntary sector groups in the area. And they helped us to produce the wording of those statements so that they'd be understandable to the public. We got just under 4,000 responses to that particular survey, but we also held a number of focus groups with particular populations so that we could understand different priorities and preferences. And if you just move on to the next slide, please, Stephen. What we've done in the full engagement report that, as I said, you can read in your own time, we've looked at those different responses across different population cohorts to try and understand whether the views and perspectives were different across different areas. So the next slide again just shows you some of the kind of priorities and preferences of those different groups, which you can see from at a glance are largely the same, although there were some differences, and that comes through in some of the work that we've done following that. If you just move on to the next slide, please. We also, through this piece of engagement, asked a lot of qualitative questions, so open questions so that people could provide us with information about things that are most important to them, understanding what makes for positive patient experiences, what their ideas were around the different types of things that we could do when thinking about the future of hospital services. And again, there's all of the responses have been coded and they're in that full report. But the key things that just wanted to highlight today that we that have helped to shape some of the potential models of care as we've been developing them and as we're still developing that pre-consultation business case. Around about things like travel and accessibility, whilst it didn't rank highly in the overall preferences and priorities when people were asked to rank them. We did get a lot of responses around the actual experience of getting to hospital services, the availability of car parking spaces, where they were in relation to the doors and the different access points. So all of those things are really helpful and useful feedback, particularly when thinking about capital investment and how we design our hospitals of the future, and making them so that they're designed in a way that fit around the priorities and the specific needs that people have shared with us. One of the pieces of follow-up work that we did around What Matters to You, which we don't have a slide for this yet because we haven't completed the engagement, it's just finishing over the next week or two, was some work that we did with children and young people as well. So, sorry, Stephen, if you can just flip back up to the previous slide. What you'll have seen with the different cohort analysis was that we got a very small response from our younger population, so under 25s. So we've run a bespoke piece of engagement work, which we co-designed with a group of children and young people to use puzzles and pictures and other things in terms so that we could ask the same sorts of questions, but in a way that was more age appropriate. And that's been delivered through our patient experience teams in both hospital trusts with the children and young people who've been using those services over the last couple of weeks. And one of the themes that's come out through that is in terms of the physical environment that the children and young people are being treated in. And again, we want to use those responses to help shape our designs for buildings for the future. So yeah, following on from what matters to you, we also have been working over the course of this year on a piece of engagement, particularly to support the work that we've been doing around maternity, but also linked to that neonatal services, so services for newborn babies that need extra care, and also the link into broader paediatrics children's services. Now, when designing this piece of engagement, we felt it was really important to work with service users and their representatives. So we co-designed the survey in terms of the specific questions that were asked and how they were asked, and the way in which we advertised and shared this. We worked with our Maternity Voices partnerships. So those are service user-led groups working with midwives and other professionals. And we engaged with the MVP for Northern Lincolnshire, Hull and East Riding, but and also the MVP for Lincolnshire, and they were heavily involved in designing this piece of work, recognising those broader flows of service users into our maternity services. In terms of the responses to that, the Your Birthing Choices piece of engagement, we had just over 1,000 responses from around the area. And you can see from the slide some of the snapshot, sort of what people were telling us through that. And that has helped to feed into and to shape some of the potential models that we'll put forward around about maternity care. So again, building from that co-production with local women and groups. And yeah, can move on now. Thank you, Stephen. And one of the other key areas, core services that we will be looking at through this piece of work is urgent emergency care services. And again, I'm really keen to understand people's views and perspectives on using our urgent care services. So we undertook a piece of work with people who'd used A&E or emergency departments in the summer of last year, and again around about 2,000 responses to that particular survey. What we found through that was that there was a large number of people who attended ED because they were advised to go by someone within the healthcare system. So that again has been really important in terms of how we design our future services going forwards. I think that might be my last slide. Oh no, there is one more. Sorry. So the last one there, just in terms of, and again, this is just a snapshot, and there's a full report that sits behind this, which should be in your background papers. We've also been doing a lot of engagement and work with our staff and teams, recognising that they are really important in terms of their views and perspectives. So again, key themes you can get through this slide and in that wider report. And I'm going to pause there because I realise I've taken more time than was allocated. So
Thanks, Lindsay. So just really to wrap up, Chair, we'll quickly canter through. I think we've got issues about standards, and members we may wish to ask us loads of questions, but we do struggle around some staffing, particularly in the areas of specialist doctors, whether they be oncologists, haematologists, etc. We need to be looking at alternative models. We need to be looking at different ways of splitting our staff. We need to be recruiting and retaining more locally where possible. Our infrastructure is poor, so just giving you an NLAG perspective, £97.7 million worth of backlog maintenance exists in NLAG. 82.6% of Scunthorpe Hospital's critical infrastructure is at risk of failing in 6 years' time. So we need to do something. And I think the pandemic has highlighted, just as a final point on this, that we have protected as an organisation our elective care. We have not stood it down during the pandemic, hence the performance that we've got is one of the best nationally. But actually, we don't operate very effectively because we use the same theatres for elective and emergency care. So we need to think it through. We need to be looking at how we give our citizens a better service, and we need to be making sure we support the staff. So the next slide really is a summary as what we know so far. We've already covered most of that, and I won't really cover that. But the next slide just says where we're at. And I think important to recognise that we're in a way, an early stage of a reconfiguration programme. We're going through the pre-consultation business case development process. Our objective will be that we will engage on that document, get to some preferred ways forward, not a preferred option that we submit for the public to make a choice on in a consultation, as we alluded to in the spring of next year. And in doing that, that we evidence why those changes are there. Lindsay alluded to evaluation. That's going to be fundamental. We need to look at standards. We need to look at money. We need to look at people. We need to look at infrastructure. We need to look at quality. And I think fundamentally and importantly, given the populations we serve, we need to be looking at equalities and inequalities as we go. So the final slide really just gives you the conclusion. The system does need to change. We're in a process of going through that evaluation of potential models. Lindsay's original slide alluded to the fact that I think hiding her light under a bushel, we have had 850 clinical staff engaged in the development of those clinical models. We've had national reviews from NHS England, colleges, peer reviews, and operational delivery network reviews. And I think that's important because actually as we move into this, we are recognised as an exemplar of pre-consultation engagement nationally. We need to build on that. There's always more we can do, and we will seek to continue to do that. And I think importantly, any decision on that final consideration is not going to be made until we have done a public consultation, until we have listened, until we have reflected, and that won't be complete till late 2022. There are some issues and risks for us, as you're probably all well aware. The Health and Care Bill is not an act yet. That may give us some issues about approval processes. That may increase some timescales, and that may in itself change some scrutiny and joint arrangements. So we need to be mindful of that. We need to build that in. We're seeking our local authority partners' considered views on that. I had some meetings with a couple of chief execs last night to discuss that. So that really is hopefully a very, very quick counter through, Chair. I was conscious we had a very brief time. Overview as to where we are. Certainly welcome colleagues' thoughts, questions, and anything you wish to add as we move forward for us to consider. Thank you.
Okay, thank you very much for the presentation. I've got Councillor Parkin first, please, with a question.
Thank you, Chairman. Can I thank you all ever so much for coming? As a twin-hatted councillor who sits on East Lindsey and represents Louth, it's really important, I think, for us to hear from you directly, and I do appreciate you coming. And I really appreciated the honesty of the report. And I thought you were very frank and very pragmatic in terms of the difficulties and challenges that you face. And I really appreciate the report didn't try and dress any of that up and hide behind anything. So thank you for that honesty. I know Grimsby well, having had my 4 kids there and numerous trips to A&E with the said 4 kids. And, I understand the challenges of kind of like that cross-border, do we go to Grimsby, do we go to Lincoln, where do we hedge our bets? And I think what I'm really interested in, this is of massive importance to my residents in that Louth there, and I'm sure Councillor Matthews will say the same about his on the coast as well. And so rather than kind of drilling down into the clinical changes at this point, what I'm really interested in is what would consultation look like in that end of the woods for East Lindsey, both with the district council, but also potentially with the parishes and with the communities there as well. How will that work? How will that look? And what is it that you're proactively doing to reach out, as I say, particularly to the district council, to be a key player in that consultation?
I think one of the things we'd hope to do, Councillor, and thank you very much for the question, and thank you actually very much for acknowledging the work that's been put in the honesty. So thank you very much for that. I think in terms of the next steps as we move forward, one of the things we will be bringing back, or hopefully bringing back should you wish to receive it, is what our plan for that consultation will be. I think traditionally consultations haven't necessarily been pre-briefed. That's something for us to think through, given your question for particularly actually more local district and parish councils. So that's maybe something for us to think through about how we pre-brief on that consultation. We certainly would be seeking your views and agreement on what the consultation document looks like. That consultation will be open to 100% of the population. And we just need to make sure that we're doing that. I think we need to make sure we do that by paper. We need to make sure we do it digitally. We need to provide free form text. Some of the bigger ones I've done in the past, I've used 24/7 helplines for 2 to 8 weeks. So I think we need to put that package together. In my honest moment, we've not thought through it fully because we're trying to work through the options at this point in time, but certainly take on board those comments in terms of making sure we engage. But we will be coming back to seek your approval in terms of moving forward to that consultation.
Thank you. I've got Councillor Smith next.
Thank you, Chairman. Just as the new boy, if you like, how did the physical assets and infrastructure get to the level that they are, that in 6 years' time there could be quite serious failures? I'd be interested to know. And you've outlined the improvement plan and where you're going, which I appreciate is a very long process. But how did it get to that stage first? And my second question is, especially with the vote that was held in Parliament yesterday around recruitment and having to be vaccinated, are you having issues around retention as well as recruitment with certain members of staff that are not vaccinated for various reasons?
Thank you, Councillor. In terms of physical assets, I think I'm a new boy in the system, so I've been in the system roughly 2 years, but I'll give you the technical answer. Both NLAG and Huth are small hospitals. In terms of their overarching turnover, the amount of capital that is allocated within the NHS is either based on loan capital or a percentage of the depreciation of your major asset base. So NLAG's capital programme, when I arrived through internal funding, was about 11 million a year. So part of the investment in your infrastructure to maintain old buildings actually is very, very different when you're just trying to cover some backlog maintenance as your buildings deteriorate, let alone invest in what those buildings are for the future. So the way NHS funding works thereafter is you apply to be on national programmes. Those national programmes then give you the allocation of the funding and you service the debt for that over a 25 to 30 year period. So I suspect mostly driven by the fact of depreciation funding. There may be a criticism you could levy about getting on the National Hospitals Programme earlier. That may be a challenge that I think the system could accept potentially. But equally, people who are on that programme have infrastructure that is probably worse than some of the infrastructure we've got at this point in time. In terms of vaccine status at this point in time, there are a reasonably high number, over 90% assumed at this point in time, because some of the staff have been vaccinated elsewhere. And we don't have access to those patients' records of a significant number of double vaccinated and boosted staff. Are we experiencing retention problems at this moment in time? Not to the best of our knowledge, but that doesn't mean as we move forward, given people's personal views, etc., that may not become an issue for us as we move forward. But at this point in time, it's not an issue for us. And we do have a significantly high number of double vaccinated and boosted staff. Thank you.
Thank you. Councillor Matthews.
Thank you very much, and thank you very much for your report. I represent the Alford and Sutton ward, and I'm just intrigued to see that you received £50.3 million of acute hospital activity from Northern Lincolnshire and Gould Trust, but I think you've had quite a lot of money from our trust as well, but I'm not sure how that's tracked. I just want to say how good it is that you're entering this review in a pragmatic and realistic and an honourable way, really, by laying out the blemishes and laying out the opportunities. But I want to address this. If I were an ambulance driver, so I'm creating a little dream world in my head now, but if I were an ambulance driver and I got to Alseby Cross, which is on the major road, it would take me 43 minutes to get to Grimsby, and it would be 27 miles on a very good road, actually. if I wanted to go to Grantham, it would take 1 hour and 15 minutes. It's 47.3 miles. If I want to go to Lincoln, it would take me 54 minutes at 32 miles. Those are all just as of a Wednesday at about 12:30. So clearly those times vary depending on whether it's rush hour. If I want to go to Hull, it's still only 1 hour and 15 minutes, but it's slightly longer. It's 55.2. What I'm saying to you is, I understand that there are different, hospital organisations and trusts and groups, but in fact, for the client group, the patients on the East Coast, you're a very, very, very viable option, and we'd want you to bear that in mind, because clearly the funding follows the bums on the seats. And I would say, in some respect, I wouldn't want to compare, but our residents look to Grimsby first rather than Lincoln, and we want you to understand that. Thank you.
Thank you. I think that's a point well made. Just maybe for members' benefit, one of the things we're in the process of doing is we are geographically mapping every patient by every condition, by every transfer to whichever hospital they have been to that we have looked after, so that we can model any potential impact on any of those patients should any of those services move. I think the other thing from an ambulance perspective is the crews make decisions based on their clinical judgment on scene. They make a decision based on potential transfer times, and they also make a decision in terms of the handover times that they get as well. So they don't always go to the most local, but they make that as their individual clinical decision on scene. Thank you, Chair.
Thank you. Councillor Woodliff.
Thank you, Chairman. Reading the report and seeing the situation in front of us, I wonder really whether the time has come to end the business of trusts themselves and start to run a National Health Service as a National Health Service. Then it wouldn't really matter whether we went to Grimsby or to Pilgrim or to Grantham or whatever, because it would all be one organisation. We've got all these little organisations, it seems to me, across the country, all these different so-called trusts. Perhaps the time has come to get rid of all the trusts and run the NHS as a National Health Service for once. Maybe we might find that we spend less money on administration and less money on all the other problems of it, and actually spend the money on the patients, which is where it's supposed to go. So perhaps the time has come to revise all this. I found that reading a report about the state of buildings in your trust and so on, it's horrific, really. I just wonder what's been going on. I've really got no questions as such. I think you seem to have all the questions. You're asking all the right questions. Hope you can get the right answers. I better leave it at that, Chairman. I don't think I can answer a question. It's not really our area, is it? It's such. But I do think that the time is, perhaps, the time is to get rid of the trusts and let's get back to a National Health Service. Do you agree?
I think it's a difficult question to be answered by our colleagues that have joined us today, and I will let them duck out of that.
Thank you, Chairman. That's fair enough. I understand.
Thank you. Do we have any other further speakers? No? In which case, I have a number of questions, if I may, so I'll just do them one at a time, if you could answer in that manner, please. So, on page 78, paragraph 72 refers to an expression of interest for £720 million as part of the new hospitals programme. Are you able to give any details of what this funding would cover, and when is the government likely to make a decision on this? And should you not gain this funding, what impact will this have on the acute service programme, please?
Yeah, thank you, Chair. So the Prime Minister announced a potential 8 additional hospitals earlier in this year to be added to the National Hospitals Programme, which is currently 32 sites. Expressions of interest were asked nationally, and 300 plus expressions of interest went into the pot on the 9th of September, of which we were one. Those have been through an evaluation. 120 schemes have now been identified as requiring capital nationally. There are 3 within the North Eastern Yorkshire region, of which we are one, that have been prioritised, and that is currently going through a regional review with the regional director. In terms of the outcome of that, we have been told to either be expected to provide some additional information in addition to the expression of interest that was submitted, or to await notification as to whether we have been successful or not, which will be by March, all things being equal, subject to Treasury approval, because it will be a Treasury approved scheme as opposed to any other. In terms of the detail that sits behind it, I think that 720 mil breaks down into 3 schemes. It's 350 million to rebuild Scunthorpe completely, 120 million to put some back-end infrastructure, particularly in critical care, in Diana, Princess of Wales and Grimsby, and 250 million to rebuild part of Hull's Tower block, which does have its most critically ill patients in it and is not fit for purpose, along with some day surgery units on the Castle Hill site. If we don't get the money, I think that's probably where we end up having another discussion as well, because we do need to look at Plan B, as members have noted. The infrastructure is not fit for purpose and doesn't support modern methods of clinical care, and it's not ideal. So we do need to look at that Plan B. That Plan B could be, could we get additional loan capital through DHSC? Can we do it in slightly different sizes and different chunks? Or do we look to alternative sources of funding? Most common ones at the moment are local government pension funds, but other sources of funding are available, and we'd have to look at those. And we'd have to work through the cost of the borrowing, the cost of the repayment periods, the spread, the yield, the term, and the equity as we did that. So we are currently looking at those options. I'm not saying those will be the options, but if we don't get it, we can't not do anything. Thank you, Chair.
Okay, thank you for your answer. My next question is, on page 116, paragraph 37 refers to 58% of mothers not supporting a standalone midwifery-led unit. Has this lack of support in effect ruled out developing any option, including a standalone midwifery-led unit?
Lindsay, do you want to pick that up?
So I think what I'll say in terms of the responses to the report, those are the high level views. We asked one of the reasons for doing this piece of work was to understand what women's views were around using those services. At this point, nothing's ruled in and ruled out because we've got a public consultation process to go through. However, we do need to look at whether such a solution would be viable and continue to do that, talking and listening and engaging with people. But we are reflecting on all of the feedback that we've gathered through that report. One of the things that you'll see when the full report's finalised is that those preferences and viewpoints are different for different populations. So there was higher degree of support for it in some parts of the area versus others. And I think whatever we would do, we would need to have further conversations with women and service users to really genuinely understand what their views are on that particular service model.
Okay, thank you for that answer. What feedback have you received from staff regarding on the possibility of moving to a single workforce across the 2 trusts?
So where we are at the moment, through the work that Claire's been doing on Programme 1, is we have created a committee in common across both boards, which is got delegated authority of each organisation to take strategic decisions on behalf of it. As we've gone through Programme 1, some of it is we've combined our clinical teams. Employees remain employed by their host organisation, but they operate across sites, partly driven by, in these cases, fragile and vulnerable specialties where actually we do have a lack of staff, notably oncology being a really good case in point actually at this moment in time. We're trying to maintain some services locally as best we can for those, but if you need to see a consultant and have some specialist interventions, then those are moving to more central locations. In terms of the staff feedback, I think it varies, would be my view. From what we've heard, particularly, we've done a number of sessions with union colleagues and we've done some drop-in sessions. I think we get mixed views by different types of staff, by different grades of staff. And I think the other thing we've done is we've mapped all of those as to where they live, where they work, and what the implications may be. There's more we need to do on that to better understand it. We've got some initial feedback. Some people are happy to move, happy to travel, and some people are not, and that's something we need to take into consideration as we move forward.
Okay, thank you. How closely are you working with your neighbouring CCGs and health trusts regarding your plans and how it may affect them?
So from I took on the overarching director's role, which was last November. I think the first sessions we had were around about February. We meet Lincoln colleagues once a month. We meet colleagues from Doncaster once a month as well. One of the things that's in the gateway review for any pre-consultation will be about not destabilising a neighbouring health economy. There may be transfers between them, but there could be transfers both ways for changes that might have a net zero impact. Equally, we cannot destabilise another health system, so that is an effective consideration of the evaluation that we're undertaking at this point in time.
Thank you, which leads me nicely on to my next question. What impact do you foresee that the proposed acute service review programme will have on the residents of Lincolnshire, and how do you plan on mitigating this?
So it may be early days to answer that, Chair. I think because we don't know what that option would be, and we won't know that till we've consulted, it's a difficult question to look at. Depending on where services may be provided, depending on the options, the answer to that question could be multiple and many. I think the key thing for us is to make sure that as we put that to the public, we suggest what the potential mitigations may be. There may be opportunities, there may be stuff closer to people, there may be stuff that maybe they have to travel more for. I think it's important we put that to the public and we listen to what they tell us and we respond to that, as Lindsay has rightly said.
Okay, thank you. I've got another councillor that's just came in that would like to ask a question, and then I'm going to close the debate down and move to the proposal. Councillor White.
No, I'd just like to say that I appreciate the quality of your research and the framing and presentation of the questions, the numbers throughout, and links to further details. Thank you.
Thank you. In which case, I'm going to move to the proposal. I'd like to propose that we note the details presented in this report and appendices, including the reasons for change, the work undertaken to date, and the next steps as part of the Humber Acute Services Programme. I also propose that we note the intention to complete a pre-consultation business case in early 2022 for the Humber Acute Service Programme, with the aim of formally consulting on potential clinical models with the public and other stakeholders in spring 2022. I'd also move that we note that the current legislative framework governing statutory consultation with local authorities in relation to the NHS reconfiguration proposals, recognising existing health scrutiny arrangements and provisions may change as the current Health and Care Bill 2021 is enacted and becomes law. I'd also like to propose we prepare a formal response for approval at the next meeting of the committee, which would identify the aspects where further detailed information is required, to state how the committee would like to be engaged over the next phase of the programme, and finally to propose we request a further update to be provided to the committee in 6 months' time, unless there is a need for consideration before then. Do I have a seconder to my proposal? Thank you, Councillor Linda Woodson. All those in favour, please show. Thank you, that's supported. And I'd just like to thank our presenters for attending today. We'll look forward to speaking to you again in the future. And once again, thank you for the quality of the report. And we wish you all a very Merry Christmas.
Thank you, Chair. Take care. Bye.
Okay, in which case I'd now like to move to agenda item 8, the work programme. Simon.
Yes, thank you, Chairman. The work programme report is set out on pages 135 to 138 of the agenda. The items listed for the January meeting are on pages 136 and 137. There is an error in that numbers 1 and 2 are identical, There is a plan, there is an intention to consider both the update of Lakeside Medical Practice Stamford and the lessons learned from that process as one item at the next meeting, Chairman. We're also, there are a number of other items on the list. I need to check in particular whether nuclear medicine is coming forward, because I don't believe that has yet been on the agenda for the ULHT board, and it's for them to consider first. So there are a number of issues to check before we finalise the list, because it does look rather a long list for the committee in January. I think that's it. The other items are listed there. The one other issue is that at the last meeting, dental services, the dental services people from NHS England presented, and they were asked for an update in 6 months, which should have really put them on the May agenda, but they have asked to go on the June agenda, and I'm sorry the tables don't include June, but I suppose if the committee was insistent, we could bring them in for the 18th of May and not the 15th of June. Thank you, Chairman.
Thank you, Simon. I've got Councillor Matthews first, please.
Can I just thank you for your indulgences? On the 19th of January, we've got East Midlands Ambulance Service providing an update, and that's really good news that they're coming. Is it possible, is it too late at this stage to also ask them to ask what they're doing about crystal gazing in terms of crystal ball gazing, in terms of the outcomes of the consultation with regard to the things we discussed this meeting and last meeting about stroke provision moving to Lincoln and orthopaedic. So what's their planning, if you like, and that relates to the questions I asked earlier. It may be too late to ask that question, but it'd be really helpful to know what plans they would have if those changes come about. Secondly, the coroner's report was published yesterday or earlier this week, and amongst that was 75 deaths by suicide. We produced a Lincolnshire audit of suicide, and that has a figure of 90. I'm not suggesting there's an anomaly there, because they have different classifications probably. But I would really like to know from someone the match between mental health provision and death by suicide at the point of emergency, if you like. And I don't know the right words, and I don't know who would speak to that, whether it's the police or the Coroner's Office or Public Health England or the United Hospital Trust. But I am concerned that there are gaps within the overall matrix of security about mental health provision, about police support, and about suicide and other associated things. So I've asked that. I'm ever so sorry. I don't know the question I'm asking, if you like, but perhaps Simon or you can use your skills to put that in. I would like to have a look at that, please.
Yeah, thank you, Councillor Matthews. With the EMIS forward plan, I think that's a fantastic idea. It's certainly something we will push them for, because absolutely, you know, we're told by our NHS CCG colleagues that EMAS are quite content with the plans going forwards and they don't see an issue, but to get it from the horse's mouth, so to speak, I think is only sensible. And so we'll ensure that that is added onto there. We did look at suicide prevention before, and Dr. Kaali Chowdhury was looking at it for us. Unfortunately, she's now left the organisation, and so it has sort of fell off the radar, so to speak. But we will pick this back up with public health, because it was the public health department that was going to move forward and bring us something to this committee. So I'll go over to you now, Councillor Matthews.
Can I, sorry, I'll just come back on that. We have a new professional, Lucy Gavins, who works in public health, and she's picked that reins up, and I'm engaged in dialogue with her and with the police, and I think that she would probably welcome the opportunity for this to be put under the spotlight as well, based on not what she's inherited, but based on the fact that COVID has brought a significant change in issues quite recently, and I think it needs another look. Thank you.
Thank you, Councillor Matthews. Yeah, Simon's got that noted down, and we'll take it forwards to our agenda setting meeting. So, yeah, I've got Councillor Cleaver first, please.
Thank you, Mr. Chairman. On the question of the two items that were listed for the
consideration of Lakeside Stamford. I personally think it would be better to have two separate items because there's actually two separate issues. One is about the CCG's tactical response to the latest CQC inspection report, which may not have been published by January. So that item might be more effective and more appropriate to be held in February. I believe it's a 6 months follow-up to a June inspection. So the June inspection, which found them inadequate. So it's unlikely that that would have been published. However, the other item, which is the strategic lessons learnt by the CCG, and actually relates to all its interactions with Lakeside, since Lakeside took over the monopoly of Stamford's GP provision. That was actually said in the September meeting when the CCG had the item on the agenda then. They specifically said that report was being considered internally that very day, and it did cover everything, not just the issues about the CQC inspections. And it was also said that they would welcome us discussing the public version of the report, inferring that there is an internal version of the report that we would not be welcome to see. And I wonder whether it would be more appropriate for us to see the full report rather than the public version. I leave that to the chair's discretion, but I would just like to put that on record. So yes, I mean, I just do think it should be two separate items because they are two very specific, different aspects of the same issue. CCG lessons learned is, of course, a strategic document about lessons learned which will apply elsewhere, which is quite different from its tactical response to helping Lakeside get itself back on its feet. So I would like to propose that. Just to follow up on the dental issues there were a number of criticisms made, I think, during the last meeting of the presentation, the report that was given. Not so much the public health aspect, which was very, very detailed, and I think that we were all very, very much interested in seeing. But the report on the actual service levels was lacking in a lot of detail. And I'd just like to make sure that when they come back to us, that level of detail will be put in. Because I noticed, in the paper, the reference to the dental services on page 138 only mentions changes to the commissioning arrangements and doesn't mention a sort of comeback from or a response to the comments we made when the dental people spoke to us last time.
Thank you, Councillor Cleaver. It does sometimes not look like there's everything that we've picked up upon, but obviously we have that when we have our meeting, and obviously we have those notes. Simon, do you want to pop in?
Yes, in relation to the content of the paper from NHS England on dental services, I've had an exchange of emails with the report author, and they are aware of what they need to include in their next report. So apologies it wasn't on the list. It kind of slipped off. It should really be, I suppose, there should have been a June box there. So it should have actually been covered in that, but thank you.
Thank you.
Thank you. And I think in terms of whether it be June, I think we should push them for May. We said 6 months. There's plenty of time to get prepared for it. So worst comes to worst, it will have to be June, but I'd rather it was as we suggested. In regards to Lakeside, we will look at this and speak to our clinical commissioning colleagues. The problem I always have is if you do separate items on what is invariably the same, then what happens is the questions just all come at the same time, and then you don't end up with two separate presentations. So it is often better that it is presented together, even if it is, we'll do one section now, we'll do section 2, and then at the end we take all the questions. So, but Simon and I and Linda will look into that to try and find the right route forwards with that. So,
thank you.
Yeah, of course, yeah, I know you have, yes. Yeah, thank you. That's okay. Thank you, Councillor Parkin. Right, Councillor Smith, you're next, please.
Thank you, Chairman. It goes back to the point on suicides, and I do declare a non-pecuniary interest as I'm a member of the Veteran Advisory and Pension Committee for the East Midlands, which is what my question relates to, is can we, in the suicide paper, have information on the number of not just veterans, but also the number of wives of or other wider forces community, which includes sons of, daughters of, and the impact that it has on them if that information is available, because often that is overlooked. I know there is a campaign at the moment in terms of registering it with coroners. I know that's not law at the moment. I know there's a big campaign on that. It's something I personally support, which you won't be surprised to know, but I think that information is very important to have because we need to be looking after our forces community, and we need to know if there is an epidemic in there of suicide that's higher than the general population, and if there are specific triggers either in time, i.e. time of year, say Christmas, or other external factors, and if there's anything we can do to prevent them from happening.
Yes, thank you, Councillor Smith. We'll take that on board and take it forward and see what we can do in regards to that element as well. I've got Dr. Wookie next.
It's not for me to get involved in the programme for the committee, but just for information, HW Links, which is we're the parent charity that does the Healthwatch contract, we've been commissioned to do some work on suicide prevention, which has been ongoing for some while now. And the first part is complete, and the second part, I think, is about to commence. But a good deal of information has been learnt already. Now, it just might be worth you having a word with Sarah Fletcher to see exactly where we are and whether we're in a position to share some of that. But I think it's a very important subject.
Thank you, Dr. Wookie, and I think that'll be very useful, so thank you for that suggestion. We'll have a word with Sarah and ensure that that's picked up upon. I don't have any other speakers. Oh, yep, Councillor Allen.
Thank you, Chairman. It's on the future work programme, obviously, and it's to do with the items that might go on to future committee meetings. And I'm desperately trying to find it now, because I've been trying to find the reference that I was going to refer to. There's one on, it's on the items to be added. It's on staffing challenges at our hospitals. And we've had lots of discussions about that and the difficulty of getting the right resources in, and so much of what faces us, I think, is greatly dependent on having the right resources in the right place at the right time. There was an item in the Humber report that was quite interesting, if not worrying, and that is that 30% of their staff are going to retire in the next 5 to 10 years. I just wondered whether there was any information that, of a similar sort of thing that could be given to us from Lincolnshire, because it's a bit worrying if we can't get resources in to fill current vacancies if 30% of our staff is due to retire in the next 5 to 10 years as well, and what sort of planning is in hand with our colleagues in the NHS, local NHS, in terms of actually either identifying the issue or identifying and dealing with the issue.
Thank you,
so it's a slightly bigger item, maybe, I think, than perhaps what we thought.
Yeah, absolutely, and we are starting to see some gaps in space as we start getting through the acute services review, and obviously the working group, which we'll be setting up dates for very shortly, I would have thought. We'll look at adding that onto there because it is a huge problem, and it is recruitment retention throughout the whole of the United Kingdom that's the major problem. And so with every trust and every county, I would say, having a problem, yeah, we're going to come up against it at some point, even worse than where we are at the moment. Yeah. And with the best will in the world, with all the changes that they wish, they may feel that they can recruit and retain better as it stands. But if then retirement hits in large numbers, then you're back to square one, aren't you? So I think we will pick that up.
And the other thing is, Chairman, if the COVID crisis does come to an end, a lot of people may well feel it's they're so tired and it's the right time to actually take early retirement or take retirement.
Absolutely, thank you. Okay, any further speakers on the work programme? No? Okay, in which case then I think we've commented and updated, and that brings the meeting to a close. So thank you all for your attendance today. I wish you all a very Merry Christmas and look forward to seeing you in the new year. Thank you.